Hello and welcome, everyone. Just going to give folks a moment to travel through cyberspace here, enter our room. All right. Welcome to the Crisis Response Improvement Strategy Committee meeting. This is actually our 11th meeting together. And I am Jamie Strauss-Clark, your facilitator. It is good to see all of you. Welcome, CRIS Committee members, welcome community members, and welcome staff and steering committee members. Before we get started with our agenda, I do want to do what I always do and take a moment to remind everybody about how we use the Zoom platform that we're on today. I'm going to walk you through two slides. The first one is for CRIS Committee members, and the second one is for guests and community members who are joining us today. So, and Chloe is going to advance the little arrows to show you the tools that I'm talking about. I first want to remind everyone, if you could please keep your mics on mute unless you're speaking. That again just avoids background noise, distractions, and us talking over each other. CRIS Committee members, if it is available to you, both from a personal bandwidth and a internet bandwidth standpoint, to have your video on today, especially for our discussion period, that would be really appreciated. That really does help us engage and connect with each other closer to like we were in a room together. And that button is next to the mute button at the bottom of your screen, your Zoom screen on the toolbar. Okay, click ahead, please. We use the raise your hand button to indicate when we want to speak. So to find that, you'll find that reactions button on your toolbar. Click on that and you'll see raise your hand. I think it's *6 or *9. I apologize, I'm not remembering if you're calling in from a phone. And as I always offer you, if all else fails and you can't find it in the moment, just wave your hands at me and I will do my best to call on you in the order in which I see hands raised. I also invite CRIS Committee members to contribute your thoughts via chat if you feel like your words are better expressed in writing rather than verbal. Please also indicate in your chat message to me, Jamie Strauss-Clark, indicate if you would prefer that I not attribute the comment to you. If you'd rather contribute it anonymously, that's okay, just let me know. And what I will do is call on folks raising their hands and then pause and review the chat. So that chat button's at the bottom of your screen and you can send that chat directly to me. If you have any technical difficulties, you can also chat to Brittany Thompson. She's here to help you address any technical difficulties that are within our control. Advance the button one more time, please. All right, and then as a reminder, if you'd like to see as many CRIS Committee members as possible on the screen, you can click on that speaker view button and change it to gallery. Okay, next screen, please. All right, this is a very similar slide for our members of the public. Again, please keep your mics on mute today. And I would ask members of the public, if you could please keep your video cameras off. And that's unless you're going to be at the very end of the meeting participating in the public comment. That just helps us distinguish between CRIS Committee members and members of the public when we're facilitating. If you could advance the arrow, please. Again, a reminder, you can click on that speaker view and change to gallery and you can see everyone on your screen. Finally, I want to let folks know we have 2 ASL interpreters with us today for folks who need that support. They are pinned to your screen. So if you don't need that, you can undo that pin, but they're here to support folks who need it today. All right. And I should say our ASL interpreters today are Rebecca and Mary. Thank you, Rebecca and Mary, for being with us today. All right, let's pause the Chloe. Let's pause the slides. So we have a few things to share before we go into the agenda. I am going to invite Jan Tokamoto to offer some words of welcome today. Jan, are you on? I don't see you. Okay. I'm just going to check the participants. Bear with me just a second here. Okay, I see Jan on. Jan, do you hear me?
Jen Stuber?
No, Jan Tokumoto. Sorry, Jen,
Oh,
I didn't mean to
yeah.
scare you.
No, I was like, oh my God, do I have something I'm supposed to do?
No,
Sorry.
don't worry.
Sorry, I'm driving, which is why I'm on my phone. Yeah.
No, no worries.
I'm sorry.
No, don't apologize. Thanks so much for doing this, Jan.
Good afternoon. I'm Jan Tokumoto, Chief Operating Officer for the 988 Contact Hub in Eastern Washington at Frontier Behavioral Health in Spokane. We value and appreciate the work of the CRIS Committee, community members, and people with lived experience who have contributed to our statewide discussion on how to improve the crisis response system, which is multifaceted and complex. Our collective goal to improve the crisis response system can only further the statewide discussion and efforts to expand and diversify future behavioral health mobile response teams. There is nothing more compelling than hearing personal stories that help to shape how we move forward in our planning process to change what can be done better, promote positive outcomes, and safely maintain people in our communities. Thank you for all your continued feedback, insights, and commitment to providing timely, relevant, and appropriate interventions from our crisis response system.
Thank you, Jan. Appreciate it. And I mentioned this at our last CRIS Committee meeting. I should say this again, that we are wanting to include CRIS Committee member voices as much as possible in these meetings. So if you would be interested in offering a welcome at future meetings, please reach out to me. I'll also be reaching out and extending the invitation to you all. Now is usually the point when we do a land acknowledgement, and at the last two meetings, we've used this time to highlight some of the great work that tribes are doing to improve the crisis response system, specifically around giving you information about what's happening with the Native and Strong Lifeline. We don't have a presentation today, but I wanted to say that I commit to continuing to find those opportunities to advance our knowledge of what's happening and what the tribes are doing, and that also partnership between tribes, sovereign tribes, and our state agencies and other member organizations around improving crisis response. So I want to say that, and then also personally acknowledge that I am currently on and live on the traditional land of the first people of Seattle, the Duwamish people, past and present, and want to say that I honor with gratitude the land itself and the Duwamish tribe. I recently learned actually that these land acknowledgements are actually traditional customs that date back centuries for many Native communities, not something that colonial institutions invented. And I think that's important to acknowledge, as well as my intent to show respect and honor Indigenous people and resist erasure of their stories. So that is my personal land acknowledgement today. One final thing before we go through our agenda, I want to share the sad news about the passing of a member of our community, Diana Cortez Yanez. She was an engaged member of the CRIS Lived Experience Committee and a major contributor to the crisis response field. She was also a peer specialist and international speaker and advocate for suicide prevention. She spent 30 years in the behavioral health system as a patient engaging in life-changing evidence-based therapy and as a survivor of multiple suicide attempts. Earlier this month, she passed away from complications related to diabetes. The Lived Experience Subcommittee observed a moment of silence to honor Diana, and I would like to do the same today. So I'm going to ask everyone to pause for 1 minute. Please feel free to turn off your camera if you would prefer. I'll let you know when the minute is up, but if you could please give a moment of your day to honor a tremendous contributor to our community. So let's pause for a moment here. Thank you, everyone, for taking that moment to honor Diana and her memory and contributions to our community. All right, Chloe, if you could put the slides back up on the screen, I'll walk folks through our agenda today. All right, so big day today. It's something we've been talking about doing for a few months now, and I am eager to dive into it. We'll briefly, these are our objectives for today. Of course, as ever, we want to understand where we've been, where we are now, and where we're going in the CRIS process. Answer your questions about updates in the monthly CRIS e-newsletter that came with your agenda last week. Then we want to spend a little time gathering a foundational understanding about the healthcare authorities' current and planned work to implement behavioral health mobile crisis response teams aligned with SAMHSA best practices. And this purpose is just to level set for all of us, but also inform our main discussion today, which is once we have that foundational understanding and also reflecting what we learned at last month's CRIS Committee meeting, discuss considerations related to collaboration between behavioral health and first responders. And by first responders, of course, we mean fire, EMS, emergency medical services, and law enforcement at a crisis. And then I'd like to reserve a little time at the end of that discussion. I imagine it's going to be the first of many discussions on this topic to confirm action items and next steps. And finally, hear public comment. So if you could advance the screen, please, Chloe. So here's our timing. After we're done with this portion, we're going to move into our personal story. And then we will do agency Q&A. So this is an opportunity for you to ask questions about the material that was in the newsletter that went out this month. Then there will be a presentation from HCA on implementation of mobile crisis teams and an opportunity for you to ask your questions at the end of that presentation. We're aiming for a 10-minute break at 4:55, and then when we come back together, we will dive into our discussion about considerations on collaboration between first responders and behavioral health in a crisis. We'll aim for action items and next steps at 6:15, and then go into our public comment period at 6:18. Finally, adjourn at 6:30. Let's see, if you could advance the slide, please, Chloe. Okay, before we go to personal story, we typically, as you remember, show our CRIS decision process slide that shows where we've been, where we are, and where we're going. Because of House Bill 1134, which is, I think, good news for all of us, the timeline is in flux. So we decided it's probably not going to be worthwhile today to show you that timeline. So expect that we'll hopefully have a clearer and more firm timeline at our next meeting together. But for now, we're just going to say that we're chugging along, and we will dive back into our timeline once we have a better sense of how much time we have. Finally, at the end of today's meeting is our public comment period, as we always do. There has been lower sign-up numbers for the past several meetings, so we have shortened that comment period to 10 minutes. I do have one person signed up today, so we will reserve that time at the end of the meeting for public comment. And now I'd like to turn it over to Bipasha Mukherjee to introduce what has become, I think, a really, really important part of our CRIS gatherings together, which is the personal story. Bipasha.
Sorry, my video is behaving weird. Sorry. Thank you, Jamie. My name is Bipasha, she, they pronouns, and I serve as a person with lived experience on the CRIS and its steering. It is my privilege to introduce Kristen to you all. She's been at almost all of our lived experience subcommittee meetings, which is how I got to know her. And now she helps us think more broadly about how to maximize our lived experience platform. Every time I connect with her, I learn and grow. You'll hear from her about her multifaceted lived experience journey and that she's a licensed social worker, but with an activist edge. She's one of the few people who asked why our lived experience steering member doesn't have voting ability and played a role in setting that in motion through her work with Washington Community Action Network, where she volunteers. In her words, she's a huge nerd and artist, writes beautiful haiku, which I learned of only a couple days back. She crochets, knits, sews, bakes, and reads a lot of fantasy and science fiction. She also plays video games, LARPs, and fights in buffer tournaments. Did you all know about all of that? I didn't. Go look up live action role play. It's quite an amazing world. Oh, and she has a menagerie of 16 pets, though only a few ever feature in our lived experience meetings. Chala is a cockatiel, and has so far the most to contribute. She doesn't care that we don't understand what she says, but Kristen and I believe if we could, we'd solve all our problems instantly. Folks, here's Chala's main human, here to ground and educate us. My pleasure to introduce you to Kristen.
Hello, is everyone able to hear me? Okay. My name is Kristen Wells, and I have lived experience personally as a sibling and as a spouse. As Bipasha mentioned, I'm also a licensed social worker, and I've been working in community mental health for 5.5 years. Next slide, please. My mental health journey began in elementary school. I had academic anxiety that led to a cycle of procrastination, anxious avoidance, and rushed completion of projects. My social anxiety made connecting with peers difficult. I had night terrors that resulted in me screaming and fleeing from imagined threats. And during the day, I would get so lost in reading, drawing, or daydreaming that it was hard for people to get my attention. I was seen as shy, idiosyncratic, and with my head lost in the clouds, but not problematic or disruptive, and thus unnoticed. In middle school, I began showing symptoms of an autoimmune disorder, systemic lupus erythematosus, which began with chronic pain in various joints and intense fatigue. My parents sought testing and treatment through our family doctor, but due to the nature of the phantom pain changing location and the difficulty in diagnosing rheumatological disorders, these symptoms were largely dismissed as growing pains and exhaustion from my pattern of nighttime insomnia and daytime napping. My younger sister, Jessie, also showed some early signs of behavioral health symptoms, but it wasn't until middle school that I really became aware of them. While I reacted to my distress by turning inward, Jessie lashed outward. Her behaviors led to expulsions, chaotic relationships, arguments with our parents, physical altercations, substance use, juvenile justice involvement, and running away. I didn't understand what was happening to my little sister. I was angry at my parents for not knowing what to do. Sometimes I was on Jessie's side, sometimes I was afraid of her, and the chaotic environment at home was overwhelming. Next slide, please. My own mental and physical health continued to worsen. In high school, I became increasingly depressed, had suicidal thoughts, and engaged in self-harm. As soon as I was able to drive, I began avoiding going home, staying with friends or romantic partners, or going home only to sleep. I maintained straight A's in school and didn't seek support, which made it easy for me to do as I pleased while my parents were focused elsewhere. Even my teachers were permissive due to my academic performance, not expressing concern about me sleeping under desks in class and allowing me to leave early or skip classes entirely. Despite my family's willingness to support me through college, I chose to move out and disconnect myself from them to escape the chaos at home. However, I was uncomfortable living with two strangers in my assigned dormitory and embarrassed by my night terrors. I quickly entered a new romantic relationship and began staying with that partner. This partner became controlling, manipulative, and emotionally abusive. Due to my isolation and lack of resources, I was completely dependent upon this partner. I was an easy target, and the few times anyone did notice the problem and ask me about it, I denied it. I did begin mental health counseling during this time. However, I denied the extent of the abuse by my partner, even to my therapist. I wasn't receiving any medication for my mental health symptoms, and my autoimmune disease was still undiagnosed and untreated. My parents, not knowing how else to manage my sister, sent her to a therapeutic boarding school in Utah during this time. Jessie successfully completed the program and graduated from high school, but returning home meant a sudden loss of structure. When she turned 18, my parents lost their capacity to impact the course of her recovery. She returned to old behaviors, reconnected with friends who had supported them, and began using substances again. She contacted me when she wanted things and otherwise only saw me at sporadic family dinners and holidays. At the end of my sophomore year, my abusive partner ended our relationship but didn't relinquish control. He did not allow me to leave his home for multiple days after the breakup and would convince me to return frequently after that by asserting an interest in being friends. He showered me with affection, then escalated to sexual contact every time. It took over a month to fully disengage myself from him, and I wasn't able to do it alone. It was during this time that our social community began acknowledging his problematic behaviors. I found support, and despite his longer history there, he found himself less and less welcome. Next slide, please. I had already met my husband, Jason, just after I graduated high school. We knew each other through a shared hobby and a shared weekly gaming group. A mutual friend encouraged Jason to approach me that summer. I was still dealing with my abusive ex, and Jason was navigating a messy divorce. But we were able to provide each other support. We were inseparable within weeks and engaged 8 months later. We both began more cohesive mental health treatment and received diagnoses and treatment for our physical health conditions. We've had a lot of challenges throughout our relationship, but we've always taken care of each other. He supported me while I finished my undergraduate degree. I helped him recover after a cornea transplant surgery. Jason drove me everywhere for a few months while I was having seizures. I supported him while he was disabled by a 6-month migraine. He supported me again through my social work degree. I learned how to help him manage his manic and depressive episodes. He learned how to soothe my anxiety. We took turns being the functional adult in our relationship. Life wasn't easy, but we have always been able to rely on each other. We had a large network of friends who supported us, and I was able to reconnect with my parents and my sister. In 2017, I was in my final MSW internship, and Jason was working at a lucrative job that he excelled at, but his health was deteriorating rapidly. The chronic pain from fibromyalgia became increasingly limiting. His employer was not respecting his disability accommodation. His depressive episodes became more intense and frequent, and he began having daily suicidal ideation. At his psychiatrist's recommendation, Jason took a leave of absence. I became Jason's first line of protection by staying with him when he felt unsafe, locking up medication and other risky items, and giving him individual medication doses. Medication and therapeutic interventions weren't working, so we decided to try electroconvulsive therapy, or ECT. ECT has a high rate of success in treating medication-resistant depression and suicidality, usually within 6 to 12 sessions. The treatment did work for Jason, but each time ECT was stopped or reduced, his suicidal ideation would promptly return. Next slide, please. After the first attempt to end ECT, Jason had an aborted suicide attempt. I took him to an emergency room. He entered voluntary inpatient treatment, and he was medically monitored while his lithium dose was doubled over his 6-day stay. We restarted intensive ECT, then tapered down multiple times. ECT was helping suicidal ideation reduce, but the frequent anesthesia and side effects of the ECT treatments themselves left him unable to drive, work, do chores, or even meet basic needs such as preparing food for himself. Yet his short-term disability constantly pushed for him to return to work. I graduated with my MSW just as Jason's short-term disability was ending. We needed financial support during the delay between short-term and long-term disability. I completed a rapid employment search and took a job paying well below what I had hoped to make with an MSW. I started working while taking Jason to ECT treatments 1 to 3 times a week, with no PTO and no FMLA protecting my job. When there were 3 treatments a week, Jason was safe but unable to care for himself. When there were fewer, he was able to care for himself but suffered emotionally and frequently needed my support to maintain safety. We continued this for 2 years and over 50 treatments. Next slide, please. A known side effect of ECT is memory loss. ECT causes people to forget events close to the time of their treatment, but memories months or even years before can be impacted as well. For most people, this fades in the months following their treatment, but as we progressed through this extended course of ECT, Jason's memory became increasingly impacted. This was very distressing for him, and he asked to end ECT multiple times. But with no promising alternatives and my anxiety about his safety, he was convinced to continue. Afterwards, I carried a lot of guilt, wondering whether my fear prevented me from advocating for him appropriately. Jason's final ECT treatment was 4 years ago in 2019, and even now he has almost no memory of the 10 years preceding it. He still struggles to recall even recent events. He can recall things within the same day, but as time passes, events fade into a timeless stream that is hard to place or sort through. Our whole prior life together exists only for me and in photographs. He does not remember it. Most of his adult life feels to him like stories of someone else named Jason. He does not know our friends. The professional skills he developed are gone. The life lessons he learned are missing. Over the last 4 years, he has struggled to learn who he is because it is clear that he is not the person that I and others in our life remember. I've had to set aside my assumptions of who he is, how he communicates, and what he needs. He's had to re-explore his sense of self and identity. We succeeded in keeping my husband alive, and yet the person I fell in love with is still gone. I have a different Jason now. I love this Jason both for the person I remember and for the person he is now. But without his memories of our first decade together, everything feels unfairly one-sided. All he remembers is me taking care of him, of being the one needing support. Couples counseling helped us shift out of the caregiver dynamic and relearn how to relate to each other as partners. We re-explored our ways of interacting and communicating, as my reliance on old patterns led to constant misunderstanding. We worked through a lot and have reached a place where we are able to make each other feel heard and supported. Next slide, please. Over the last 3 years, Jason has stabilized on a medication called clozapine, which due to the severe side effects and health risks, we had been hesitant to try. I have been able to return to other aspects of my life, including hobbies and friendships that he no longer has in common with me. He had become very isolated during ECT and remained so during COVID-19, partially due to my compromised immune system. In the last year, he's finally started to break through the isolation, develop friendships, and try new hobbies. In meeting with his psychiatrist recently, he realized it has been over a month since he has had suicidal thoughts. He's completed the certified peer counselor training and is starting a new job next week. It feels at last that we have come through the worst of the darkness. Next slide, please. Throughout Jason's journey, I spent years in a state of constant crisis. I worked full-time through it all, but every time I left our house, I was afraid I'd come home to find Jason dead. I cried in the car on the way to work and on the way home because it was the only time I was alone. I never went anywhere without my phone in case he called for support. I left work early or skipped social gatherings when he needed me. I was always anxious and tired, and if I let myself slow down, I fell apart. People often called me strong for supporting Jason, and while I understand the sentiment, it made me feel profoundly unseen. I did not feel strong. I felt desperate, broken, and utterly alone. I still carry this trauma with me. My anxiety still spikes if he becomes depressed. My phone is always nearby when we're not together. My chronic fatigue has rebounded, and there are days where it is challenging to remain awake for more than 3 hours at a time. I'm happy to say that my life is in a place that brings me peace despite this. I'm passionate about the mental health crisis work I do. I've developed a healthy, supportive relationship with my family, and my sister has grown into a wonderful person, stable in her own recovery. Jason and I will be celebrating our 12th wedding anniversary next weekend. I have other relationships, friendships, and hobbies that bring me joy. Thank you all for taking the time to listen to my story.
From my heart, thank you, Kristen, for how transparent you are. It's been wondrous to me to witness that since I've known you. I want to also thank Jason for giving you permission to share parts of his journey. You've clearly laid out how behavioral health journeys are complex and multifaceted, related to financial stability, housing, domestic violence, separation from family, holistic healthcare that looks at our whole body and not just behavioral health, losses that have to be contended with, like Jason's loss of his memory. You pointed out that seeing a therapist is good, but not sufficient. It takes time to build a trusting relationship with caregivers. So just 12 visits, which often is what people get, is nearly not enough. The system needs to be broader and provide deeper care. But here's what feels extra special to me in your being a person with lived experience. You take all of your life experience as a wife, a sister, your personal journey, a caregiver to your husband, and you pour that all into your work. I have heard you talk about how frustrating you find the system and how it limits you to be able to support your clients the way you want them to be supported, how it breaks your heart to not be able to provide the best options for them. Your hands are tied. We don't make it easy in workspaces to allow people to say they are people with lived experience while also being very good at their jobs. But the truth is that it's happening everywhere, all the time. And I wish we made it safer for people to own all their parts. Kristen, you use your privilege to help us bridge that false divide between client and caregiver. Thank you for being here today, for being my friend. I learn a lot from you. Thank you.
Kristen, there's not much more for me to add than to echo all of Bipasha's words and just express our gratitude as a CRIS committee for you coming and sharing your story today and for putting together these beautiful slides that gave us some faces to put to names. So thank you again for your generosity in sharing your story today. Okay, everyone. Let's see, Chloe, maybe you can stop the screen share. We can all look at each other. Let's move on to the agency Q&A. So as hopefully most of you know, we've implemented a new practice that started at the February CRIS committee meeting where you, rather than having presentations from the state agencies to update you on the work that's been done between when we meet, that's summarized in a newsletter that comes with your agenda. And so we want to reserve this time for you to ask questions or any clarifications you need based on what you read in that newsletter. I see Carrie is with us.
And Michelle is on the phone. She's just not able to join by Zoom. So
great. Okay, thank you.
We'll see her number, I think.
All right, thanks, Michelle, for being on the call. So why don't we open it up if you could use the raise your hand button, CRIS committee members, to let us know what your questions are. You also, of course, are always welcome to put them in the chat and I can relay them. Kimberly.
Hi, thank you. Hi, everyone. This is Kim Mozak with Disability Rights Washington. So I've been working with Carrie and other folks from HCA on mobile crisis response in context of the True Blood case. And I think I was just curious because I was reading the newsletter about reporting and data collection for mobile crisis response, which is we've struggled with under True Blood and talked about what we're learning and how to improve things for the programs that are associated with that settlement agreement. So I guess I'm curious sort of more largely what kind of data is being gathered statewide, not just in like the True Blood regions. And I don't know if HCA is putting that out regularly or how is that data being processed and published?
We may get a little bit more to that, Kim, in the mobile crisis response presentation that's coming up. I will give you some information that I can get from our team. Not prepared to tell you exactly today, but we will get it for you. But I do think it's worthy, right, that we had this conversation. It's so hard to collect this data, not just mobile crisis, but in the co-responder field as well, as we talked about at the last CRIS meeting. Really worthy conversation. I will find out what we have available, and Matt, Allison, team that's on the phone, I'm just going to throw this out there. If you have something to add that makes sense when you're doing your presentation, please do. For Kim's question, to be responsive. But if we don't have it for you today, Kim, we will lean in and get it for you and let you know kind of what we're able to get, what we're collecting, and kind of if we have it available, where we want to go in the future.
Thanks, I appreciate it.
Yeah, thank you.
Thanks, Carrie. So maybe we can, Nicola, maybe we can make a note of that as an action item too, that Matt and team, if they have it at at their fingertips, they'll share what they know during their presentation today. And if not, Carrie and team will follow up with CRIS to update us on what is available.
Yeah, I do have a sneaking feeling that they might get to some of it, Kim.
So your question's prescient. All right, excellent. Any other questions from CRIS committee members about what you read in the newsletter? Vipasha.
Not a question as much as a comment. So I've been doing this crisis, being a volunteer at Crisis Connections, what was Crisis Clinic, a while. And I know that there hasn't been that much conversation between, for example, Volunteers of America and what was Crisis Clinic. So reading in the report that the 3 frontier Crisis Connections and Volunteers America meeting regularly with the agencies, it made me happy to read that, honestly, because I think there's some history about, not feeling heard and seen at both ends. So that gave me a lot of hope that the agencies are meeting regularly with the call centers, and that the call centers are working together to come up with the mission. I think that's wonderful, honestly.
Thanks, Vipasha. It's nice to hear those words. And I am just quickly putting in the chat the link as a reminder to everyone, particularly our community members and guests. All of the meeting materials, including the newsletter, is on the HCA CRIS committee website. So I'll put that link in the chat so you can access it, and you can access future ones there as well. I said Kimberly before, but actually I mean Kimberly now because the other one goes by Kim. So Kimberly H.
Thank you so much. My question is just about the 988 call volume update. Interesting to see the level of calls and how that volume has increased. Are we tracking the amount of time that mobile response is doing field response as a result of 988 calls? I'm just very interested in how many of those increased calls are resulting in an in-person service rather being resolved with a telephone call.
Carrie or Michelle, is that one you can answer? Or is that one we should get back to Kimberly on?
I can have Michelle answer it, but I think just a reminder, folks, that the legislation envisions us talking about how 988 interacts with current regional crisis line deployment of these services. So Kimberly, I think great question, a little ahead of the time for some of the things that we're talking about as far as the legislation and what it recognized and where we're at now. So we don't have right now 988 doing deployment of those mobile crisis responses that were being deployed out of regional crisis lines. So there's still a lot of work that we're doing behind the scenes around how we can have efficient deployment of services kind of regardless of where someone calls. So I'm going to pause and say, Michelle from DOH.
Yeah, can you hear me?
Yeah.
Yes.
Can everybody hear me? Okay, great. So I just pulled into my driveway, so thanks for humoring me while I'm on the phone because my Zoom app was not working on my phone, but I'll be on camera shortly. But yeah, Carrie's exactly right. Like right now, if you look at the original legislation where we've got the call centers, which were the existing National Suicide Prevention Lifeline call centers, now the 988 crisis and helpline call centers. And then in the vision of the original legislation, you know, continuing into the new bill is about the call center hubs, which have those extended capabilities, including deployment of mobile teams and rapid response teams. And so that still is what's coming next. All the call centers do have a way to connect to resources in their communities as needed, but that data is not at this point being collected in a standardized way, but that is part of what was in the technology plan to collect that data in a standardized way, especially once we get to the call center hub model as well. So much more to come, and yeah, more discussions here in the future, I am sure. And I don't know if any of the call centers want to talk about, I mean, they're probably collecting some of this data, but definitely not in a consistent way statewide.
Levi, Jan, Michelle, anything to add there? Or?
I don't. I think that was a good summation by Michelle. So
I have nothing to add.
Okay.
The only thing I'll clarify is because my organization, is Michelle from CEO of Crisis Connections, our regional crisis line and our 98 region are the same. So we have more integration just because our geography is the same. So we have more integration around being able to request the mobile crisis teams and DCRs and so forth. So it's a little simpler for us in that way compared to our colleagues.
Thanks for that clarification, Michelle. CRIS committee members, any other questions about the newsletter? Well, excellent questions, everyone. And thank you, Carrie and Michelle, for jumping in on those responses. We'd love feedback on how this newsletter approach is working. So if you have any thoughts to share, please don't hesitate to reach out to me or Nicola. But I like that we're able to preserve more time for CRIS committee discussions by doing it this way. So thanks to everyone for preparing that newsletter and reviewing it ahead of time so we could do this this process. And I see some comments in the chat about people liking this approach. So all right, we're a little ahead of schedule, which is great because I'd love to preserve as much time as possible for discussion. So if Matt Gower is ready, Matt Gower with HCA, I'd like to turn it over to him to present on HCA's implementation of mobile crisis teams. And Chloe, I think we have some slides to queue up if you want to get those on the screen. All right,
Thank you, Jamie.
Take it away, Matt.
Thank you, Jamie, and thank you to the members of the CRIS committee and the public for letting me speak again on this beautiful spring day, at least here in downtown Olympia. Today, just wanted to kind of level set over our crisis system as it is, how it came to be, what are some of the mandates and mechanisms that kind of control who does what, where, and how, and then go over some of the work we have been doing in the last few months, preparing for House Bill 1477 and the implementation of 988 and how those mechanisms are used during that. And the whole goal here is to inform your discussion a little bit later on around co-responders, law enforcement, and mobile crisis and the various roles going forward. So next slide. Go ahead and go to the next slide. I always got to yawn before I start talking for some reason. So just a little bit of the history of the system and how we kind of got to where we are today. The first point is the crisis system has always served anybody and everybody, regardless of ability to pay. It doesn't matter what your insurance is. It doesn't matter if you have insurance. Most of the time, the crisis workers, the call centers, mobile crisis, don't even know what insurance you have. That's actually billed and solved on the back end, usually at the ASO regional level. Only if you go to a stabilization facility or an ENT is that even engaged before you go. So that also goes for commercial insurance as we're adding that in. The original system kind of focused on serving the most acute first. So typically followed with involuntary services through DCRs or proactive outreach to kind of prevent system overuse. So people frequently using EDs or people frequently needing crisis services, ITAs. So that really only served the most acute people. Everybody else who was in crisis was typically served through other means. And I'll get to that here in a minute. But as we started putting more resources into our behavioral health system around the time that we switched between the regional support networks to the behavioral health organizations, BHOs, and they started taking over kind of the whole system of care. So of behavioral health, that's mental health and SUD, more resources were being sent to proactively support people in crisis. These often were systems that supported people who were not enrolled and helping them get enrolled. Where for a majority of regions in our state, people who are enrolled in some sort of outpatient, they may be seen by some sort of after-hours support, like a mobile crisis team at like 7 or 8 o'clock in the afternoon, or regional crisis line, but then the follow-up is done by their enrolled clinician or somebody with that provider. So as teams as crisis services kind of started getting ramped up and pushed out more and more and built up, it was done at a very regional level to respond to regional needs. Often providers would come up with an idea, go to the BHO would fund that idea, and that resource would start to kind of go out and work within their community, solving community needs, but not necessarily from a state level of support or with guidelines around that. And I'll go over kind of what those guidelines would be here in a minute as well. So kind of getting to that data collection, we never really looked at mobile crisis data or crisis system data as a unit until really the True Blood started. That's when we started having, our True Blood settlement was in effect, and we started analyzing the data through that. Again, the reason for that is everybody did it differently. So there was no real mechanism to look at it from a statewide level and understand what's going on in the crisis system. All we would look at is that the BHOs were fulfilling their contractual obligations to provide crisis services. And I'll go over again what those minimums are here, because it's not a whole lot. It's very vague and allows for that regional variation to solve for regional needs. Under the True Blood settlement, we did start collecting data, but we only collected it in the regions where True Blood was being implemented. So the first phase of True Blood was Spokane, Southwest, and Pierce. That's only 3 out of 10 regions. Phase 2 was King, and then in the last year or two, we started collecting MCR data statewide, but it was, again, for the True Blood purposes. So over the last year, we've been making modifications to this data collection and standardizing what mobile crisis means so we can actually look at it and understand what a mobile crisis response is. But with that, there's some growing pains. And so as we've made changes to the system, we found that some of our changes didn't necessarily work very well. And so we were going back and making a very large scale change to better track all the metrics that we need for mobile crisis teams to better understand what their response is. Another point that's really important in the history of our system is the funding has never been adequate or robust enough to serve everyone. So there always has been kind of some filtering going on, a little bit of gatekeeping. Mobile crisis teams are now better able to respond to everybody in crisis, but back not that long ago, trying to make my words here very carefully, but not that long ago, people who were in not as an acute a crisis would be offered phone support because a person wouldn't be able to get out for a day or two. The goal would always be to try to respond, but it may not be as fast or as readily available as a person in crisis needed it. That would result in them going to an ED or calling 911 and getting a first responder to help with their needs. Co-response was off in most regions was developed to better serve people and accessing services through this way. So if you're a fire department and you're responding to people calling 911 for behavioral health needs frequently, you would send out a team to start working with them to figure out what their needs are and to better solve that. Sometimes that could be for medical reasons, and sometimes, and a lot of times that was for behavioral health reasons. So that's kind of the background of the system of how we got here. It started as a very reactive system to serving the most acute people who needed services but weren't always getting it, or the services they were getting were not adequate enough to support their mental health needs. And often revolved around involuntary services in the beginning. And then as we moved into the BHOs and then now into the BHASOs through integration, we've had more resources in the crisis system to be more preventative, and we're serving people in less and less acute crisis through the crisis system and trying to take that load off of the first responder and emergency department systems. Next slide. So this is just kind of a map of the BHASO regions as we go through this to kind of highlight how we do everything differently across the state. I'm originally from Spokane. They do things very differently than they do over here in Olympia. And that's for good reason, as the Spokane region is very different from the region over here. That's always been the strength of our crisis system, but it does kind of created that problem as we start to really look at it, standardize it, and try to get ready for this 988 system, that everybody's doing it differently. We don't have a common definition for anything for data, for what mobile crisis is, or even as a way of moving forward. So that's been a lot of the work that we've been doing over the last year. Next slide. So now that we kind of went over how the system went through a bit of a transformation and started building out, but still at a very regional level, never from a state down level. Just kind of give a little bit of an overview of how the system operates now. So from the state level, we receive money from the federal government and from state provisos and the operating budget. We blend that funding into contracts with our BHASOs to oversee certain crisis services. So the core services we've been talking about so far of someone to talk to through regional crisis line and someone to respond through a mobile crisis team are handled by the BHASOs. For people who are uninsured, they also handle that third part of someone to respond. But for people in Medicaid and commercial insurance, those are done through those pieces at the moment. BHASOs will then contract with providers to provide those services. BHASOs are ensuring that there is an adequate amount of services in their region. But one very important thing to keep in mind is funding comes with mandates and requirements. So if we are playing with federal money, we have to follow federal rules. So there are certain reporting requirements, and then there are certain overall requirements on how we spend and use that money. And those mandates follow from HCA through the BHASOs to the providers. I'll go over these mandates here in a minute. They're kind of dry and boring, so I will try to spruce them up a little bit. But that's a very important part to keep in mind, is that at the state level, we work with the ASOs to ensure that there is a crisis system in place. The ASOs have a bit of leeway on how that looks and what they provide, as long as they meet the core requirements to provide it. And then they work with the providers who have another level of discretion of what they call themselves, how they operate, and as long as they're meeting kind of the when they operate type thing, I guess, for mobile crisis and regional crisis lines. Next slide. So these are the mandates. These are the levers and mechanisms that ensure certain things are followed and which establish the bare minimums that we have to provide in our system and who provides it and how they provide it. Starting at the top with the federal government, there is certain entitlements in federal law that must be provided by the state, when we accept Medicaid. Those are requirements from what services are available to medical necessity requirements, et cetera. I'm not going to go into a lot of detail because they can get really, really boring very fast. But basically, the way we fulfill those requirements is set through the Medicaid state plan. This is also a very detailed document that can get pretty complicated pretty quick, but it's basically an agreement of how we will fulfill those entitlements with the federal government as a way of receiving those funds. This state plan has to be agreed upon between the state and CMS following those federal Medicaid entitlements and federal law to ensure that we are providing Medicaid appropriately. And then another piece from the federal government that we often work with is the SAMHSA block grant. SAMHSA provides funding through the mental health block grant and the substance use disorder block grant to the state to fund a lot of programs. And there's a set aside in there for us to provide crisis services through the mental health block grant. We have reporting requirements and certain funding restrictions on that block grant on what we can spend those funds on. At the state level, we have two major RCWs. There's a ton of other ones that have an impact here, but I just try to narrow it down. But we have RCW 7105, the Behavioral Health Disorders, and 7124, Community Health Behavioral Health Services Act. These are the statutes and in our state that define what must be in a crisis system and who must provide them. They follow along pretty much in lockstep with federal mandates and kind of build on that to ensure we have what we want in Washington. And then there are various legislative provisos that will come out in the budget. Probably fairly soon we'll start seeing this year's budget. But those also kind of have strings on where and how money can be spent. And then there's also the DOH licensing WACs, which follow a lot of the state plan, but then also have various requirements on who is qualified to provide services, who can have a license, credential, and provide services for in our crisis system. And then down at the regional and local level, the BHASOs can put in various contract requirements, like requirements to work with local emergency services, regions, localities, whatever different requirements ASOs want to ensure that their regions are functioning appropriately. And then there's also sometimes strings that come with local sales tax and other funding streams. So that's a lot of the mechanisms and kind of framework we build our crisis system off of. Next slide. And just, this is the simplest flowchart we could create to show you how funding flows. And it's kind of dizzying no matter how you look at it. We spend a lot of time trying to make this not so dizzying, but this is as simple as we could get it. To highlight that funding a majority of the funding for our crisis system comes from the federal government through SAMHSA and CMS. HCA gets those funds, mixes it with state dollars, contracts it down to the BHASOs. The Medicaid funding actually has to go to the MCOs, who then contract it to the BHASOs, and then it goes down to the providers as a mixed stream. And then over on the right, you have SAMHSA providing funding to Vibrant to run the 988 line at the federal level and oversee the administration of the NSPL lines. And a lot of the funding for our NSPLs in our state come through DOH through the 988 line tax. So it's kind of a separate system at the moment. Kind of going back to that question earlier from Kimberly about if we're tracking whether teams are dispatched from 988, it's still kind of a separate system that we are working and bringing into this hub model idea. So a little bit of work there to go. Next slide. So another fun piece that if you're a nerd like me is actually a lot of fun to dive into, but can probably get a little boring for a lot. How funding is determined. So these are the mechanisms we have to roll funding out in different areas. For Medicaid, it's a very hands-off piece. The federal government requires all funding to be actuarially sound, which is a very fancy term for basically making sure that the costs are correct and based on the actual payment, the payments are correct and based on the actual costs in the area. So things that are taken into account in this actuarial rate are number and acuity of enrollees. That establishes what's called a per member per month. That's a fee that the state pays managed care organizations to administer services for them. It's the premium we pay. Part of that is also in regions, what services are available. So if you have one or more PAC teams in a region, the number of PAC teams impacts that rate. And then it also takes into account the local salaries and cost of living of service providers. So a rate will be paid higher to counties like King, where cost of living is a bit higher and salaries are also a bit higher than, let's say, Yakima County, where salaries and cost of living are a little bit lower. Again, keeping that actuarially sound, and it's done by a third party, not HCA. We can provide models to them where they can use those to help kind of as a starting point of how we see a cost going down and how many staff are involved in a service delivery, but it's up to the actuary to make the final determinations. And then state funding is determined by the operating budget. So our legislators determine the budget, they send funding to HCA through various provisos or various funding mechanisms. Again, there can be strings attached to that at various levels. And that is what we provide down to our ASOs for various services. For Medicaid, there's something called a federal match. It's the percentage of money that the federal government will match based on how much we spend. So for a lot of services, it's about $1 to $1. So 50-50 split for a service. For some, like mobile crisis, right now there's an enhanced federal match that we'll be taking advantage of in July. And 85 cents will be paid for by the federal government, 15 cents by the state. So if we put 30 cents in there, then that goes up to 170 cents by the federal government, in a sense. So we do have a little bit of flexibility there, but we can't spend that money unless the legislature tells us it's for us to spend. And at the regional level, budgets can be determined by mixing funding from what we provide from HCA with local sales taxes, any other local provisos, and then also lately, new pieces being implemented where BHASOs will bill commercial insurance for what commercial insurance enrollees use for mobile crisis. And we're looking at other areas under 1688 where ASOs could be involved. But they can also move funding from one program to another to a certain degree to help fund different things. They can come up with new innovative ideas as long as they're fulfilling the requirements for operating their particular crisis system. Next slide. So just wanted to do kind of a quick exercise here of how all these mandates, all these funding streams, how they work for mobile crisis, since we've been talking about it so much. It's a kind of a fresh concept in our mind. So mobile crisis teams must meet certain standards. So from the Medicaid requirements, there are in our state plan, certain providers that can provide crisis services. Right now, that includes a mental health professional, often called an MHP. They are a master's level clinician, a prescriber, and can also be a registered nurse with a psychiatric registered nurse with, which is 2 years of experience after getting an RN working in the mental health field. They have to oversee all services being provided in the mental health crisis system by anybody else. And that other type is called a mental health care provider. These are bachelor's level clinicians or somebody with an AA and 2 years of experience. They have to be under the supervision of an MHP, but they can go out on their own and provide crisis services as long as they have that ability to staff cases and receive supervision and feedback. That's a Medicaid requirement. And because we play with Medicaid funds as a majority of our funding source, we align everything to that just to make sure that we don't run into any issues later on down the road. And then there are state RCWs and WACs. So the statutes and rules say who can provide what. In our state, behavioral health agencies, BHAs, have to be licensed and then credentialed to provide the particular crisis services. It's a little bit in flux at the moment, but for the most part, you'd have to be credentialed to provide the crisis phone support and crisis outreach WACs. Those WACs will change name on May 1st, just for an extra level of confusion. The RCWs also dictate what mental health specialists are. So certain mental health specialists, like children mental health specialists, are supposed to be working with children on an outpatient basis. Doesn't necessarily cross over into the crisis system, but just to kind of give you an idea of what is there. And then there's contract requirements. So you've heard us talk about the urgent and emergent response times for our mobile crisis teams right now. Those aren't in statute or WAC, those are in our contract terms. So they're very flexible for us to kind of edit and change to a degree. But the contract times are the minimums as part of the True Blood settlement, which helped kind of kick off this whole standardizing of mobile crisis. Other contract requirements in there are reporting. So there's a gross reporting every quarter of crisis services provided by a region. There's also requirements that our mobile crisis teams are trained in certain elements or respond with certain people, that type of thing. So again, for mobile crisis teams, the funding really comes from Medicaid and state funds. Regions can also use SAMHSA block grant funds and local dollars to support their mobile crisis teams. So knowing all that, how can changes to the program be made? Next slide. And really, when we were writing this, we kind of envisioned a bunch of strings and how they got tangled together. So we have this metaphor of how do we untangle the strings and make a easier to track, easier to understand crisis system. Next slide. So one of the ways that we can improve this, and one of the key frameworks that we're implementing in our state, is SAMHSA's best practice toolkit for crisis systems. is a combination of best practices from across the country to reduce first responder utilization and improve outcomes by using behavioral health first responses. They also recently created a youth-focused best practice guide, so crisis services for youth. But we'll only focus on kind of the generic one here, just to simplify things. It is a framework, like I said. Some of the key contributing states you may have heard of, like Arizona, Georgia, but they also pulled in some from Michigan and Indiana, as well as, I believe, a whole host of other states. But they really looked at it, and then they looked at kind of a forward-thinking approach of, okay, these states do things pretty good now, but how can we take it a step further? But it's just a framework. It bases itself off of 3 core elements that you guys are all familiar with, but I rewrote here just to kind of highlight what they mean to us. So someone to talk to, that's a regional crisis call centers right now, and we're adding 988 to that. Mobile crisis response is someone to respond, possibly more. That's part of the discussion later on. And then crisis relief center and stabilization facilities, as well as peer respites, which are opening up across the state, are a place to go. So these are the 3 core parts of our crisis system right now. The 988 and other response methods are kind of outside of that at the moment. One important thing to note on mobile crisis response that we're working on is making it more of a voluntary response. Right now, DCRs often go out in place of mobile crisis teams because that's all that's available in certain areas. So as we build up capacity, we'll be making our DCRs play the role that they're supposed to. So they will be responding to people needing an ITA investigation most of the time, and working to do that last line of looking for a least restrictive alternative, or doing the full ITA investigation in detention to free them up and give them a little bit less work to do so they can be more responsive. And then there's the essential qualities of the crisis system. And these are really important pieces that framework should be built around. So addressing recovery needs, using peers, being trauma informed. That increases engagement, that directly works to solving the crisis itself. Thinking through a lot of crises, our behavioral health symptoms can be exacerbated by things like not having enough food in our house, or having to deal with that co-occurring medical issue and not having that addressed. So really looking at a full recovery need, and using peers and being trauma informed, be aware that people have gone through a lot in their journey, and engaging them at the level they are. Implementing suicide safe care. Suicide is a very preventable death, and having suicide safe care as the forefront of our crisis system and being aware and being responsive to it is very important to ensuring that we can help people. And then making sure that safety and security for staff, for staff and those in crisis. There's a 2-way street there. We don't want to send people into unsafe situations, and we don't want our people in crisis being in unsafe situations. And then reducing law enforcement and emergency medical services utilization, but improving collaboration with them. So if they come across somebody who's in a crisis situation, handing it off to our crisis system at the earliest convenience. And if our mobile crisis teams go out and we have somebody who's medically compromised, being able to access our emergency medical services to support somebody right then and there. Coordination is kind of a theme throughout SAMHSA's best practice. And that's the other key piece to it beyond coordination is improving access. So the 988 line, the reason why we have 988 instead of going through 911 and better training 911 to answer behavioral health calls and do that triage is to improve access by giving a dedicated line. 911 is a very fast call. I believe the average call is about 5 minutes. You call, what's your emergency? 988 is, hey, what's going on with you? Let's talk. It's a much slower 15 to 20-minute phone call to really help the person work through what's going on and then get into the problem solving stage. So that's kind of the main reason we have different access points for behavioral health and 911. And we're trying to work to move those 911 calls to behavioral health. I read a statistic recently that 12% of all calls to 911 could be better served by a 988 or regional crisis line. So we want to move that volume over so that our 911 operators can do the work that they're best at. Next slide. So the avenues to improve our system, just a kind of a rehash is through contracting. That is our easiest and most flexible way of doing this. We work with our ASOs to update contracts every 6 months. That's true with our MCOs as well. We can also update WACs, and through our rulemaking process, we have the force of law, so we can enforce WACs through various means, including enforcement measures. Most common you can think of would probably through DOH, where there'd be some sort of licensing finding, which could result in less intakes or loss of license and ability to operate. And then the next hardest level is legislative changes. This is the season for it. So if you guys are interested in improving our system, we have some legislators here on the call as well, but legislation takes time. It's harder to enact, and but it is a bigger kind of hammer, I guess, bigger tool, can overcome large systemic needs. The establishment of crisis call center hubs is done through legislation, and is giving us the mandate that we are using as we move forward. But it can only be changed once a year, and it's a long process. You can probably ask them about that process they're going through right now. And then probably the hardest level is the federal level changes, and that requires us to negotiate with the federal government following their mandates. The federal government, we are spending the federal government's money, so they tend to be very picky about how we're doing that and ensuring that the services we're providing are very high quality and effective. So this slide is just kind of reframe as we go through this next exercise of what are the easiest pieces to change and what are the hardest pieces to change. So next slide. So here's how we've been implementing SAMHSA's best practices and the various mechanisms we've been doing. The establishing of crisis call center hubs. This is establishing a better coordination, a better access point. We can track data through these hubs, and we can really minimize the need to hand people off between a 988 call and an RCL, or 911 to 988 to RCL, so people only have to tell their story once. This is established by a statute and will eventually be established through rules. DOH is in the process of writing these rules of what a crisis call center hub must meet. And then there will be some contract requirements in there as well about reporting, usually metrics and things like that, to ensure that they are following the rules and any other funding requirements. Another thing that's going on is we've been expanding and standardizing mobile crisis response. Provisos were given to us a couple of years ago to ensure that there's at least one mobile crisis team in each region for youth and adult. We use the formula to determine the funding of which regions need more mobile crisis teams to reach a 2-hour response time, and distributed funding appropriately. We are tracking how those teams are being set up through contract requirements and reporting. This particular one doesn't really need any rules or any changes. We're just operating within the proviso funding we're provided and following through on contracts. And then another big change is creation of 23-hour crisis relief centers. Senate Bill 5120, for those who are interested. Right now, 23-hour facilities can operate in our state under a specific credential and endorsement through Department of Health to provide outpatient stabilization services, but it hasn't been very effective, and there's been a lot of difficulty around keeping those open and sustainable. So the legislature stepped in, creating a new model with different access standards than we have right now, and different requirements that will be implemented through statute, and then DOH will eventually write rules through it, and then HCA will also eventually write contract requirements, and DOH will probably have the same if they use 988 funds to ensure that these facilities are meeting the goals of that legislation. Next slide. So some more work that's going on that's kind of away from that model of contracts, rules, laws, SPA, all of that, this is kind of our softer approach for making systemic change. Right now, we're in the process of developing a mobile rapid response crisis team. We've been calling it mobile crisis throughout this whole mobile crisis response because, as mentioned before, it's not the same anywhere in the state. A lot of teams use the mental health professional, mental health care provider, but they may also use designated crisis responders, or maybe just consisting of designated crisis responders. We left it up to our regions to figure out what will work in their region, and it works. It may not work the best at the moment, but it's worked with the funding and support that we've given them. So we've been working to create kind of standardized staffing models, and these are going out through contracts right now. We've also worked on improving our data collection, as I mentioned earlier. We've been taking a look at what the True Blood teams have been implementing for their data requirements, and then building off of that to better track when teams go out, how fast they go out, and who and what is being served. And then we will be continuously improving these response standards and data reporting as the infrastructure allows, mostly when the Crisis Call Center Hub technology platform goes into place, because a lot of data requirements and changes are kind of burdensome on our PHASOs. So we're hoping that when the system goes in place, we'll be able to track things much quicker and much easier. We're also creating a best practice manual. This is for our mobile crisis teams, our youth teams through the MRSS model, and our crisis contact centers of really just standards that everybody should be following and using across the state, and then best practices to adopt as funding, infrastructure, and support allows. One of those best practices is transporting clients, but we can't really ask our teams to do that right now because a lot of teams are driving in their own vehicle. And if you look at the back seat of my car, I would be terrified of having somebody back there at the rate my 8-year-old can destroy it with a single box of Twinkies on a soccer trip. So we don't really want our mobile crisis teams using their vehicles. We don't ask our other first responders for them to use their personal vehicles to transport people. So that's one of the requests we're having, but we're building that up, and we're recommending that mobile crisis teams be at least involved in the transportation and to minimize the use of paramedic or other first responder transportation to lower the stigma and help the person feel more supported as they go to a facility or wherever they need to go. And then we're also working on improving that coordination with first responders, of really starting to get down to the local level of how do you coordinate with the first responders? What are some practices we can incorporate across the state and locally to make sure that if a law enforcement officer goes out to make contact with somebody, they find it's behavioral health response, how do they get a mobile crisis team there quickly so that they can go about doing the rest of their public safety duties? And along that line, we are creating the dispatch and information sharing protocols that's required in 1477. This is again to help kind of standardize that response. We're creating a decision tool in there to look at how could we divert somebody from needing a 911 service to a behavioral health service. So looking through a series of situations that are pretty common. What are some protective factors a person can employ? What are some risk factors that call takers should look at to making that determination of whether a mobile crisis response is more appropriate or a first responder. And this is an area that we'll bring up a little bit further in discussion a little bit later around co-response and the roles that can be played there. I also want to put in here, I put this on here as a shameless plug. If you're interested in reviewing and helping us develop these further, please let us know. We'll be setting up a work group with CRIS Committee members to look at this when it's a little bit more complete and a little bit more filled out. So we can get you guys' feedback and better incorporate recommendations into it. So with that shameless plug out of the way, next slide.
Matt, I'm so sorry to interrupt, but I do want to make sure we have time for Q&A. So I think this is close to your last slide. If you could wrap it up so we can get to Q&A, that would be wonderful.
Yeah, I'll go over this really quickly. We did put out a request to fulfill some of those areas I mentioned before that we need. We know we need more mobile crisis teams. We don't have enough for the response as is, especially if we're going to be speeding up to 1 hour or faster. We've asked for 17 teams this year. We know that we would need 40 more above that. Purchase vehicles for transportation and provide in-home stabilization. We also want to create standard trainings for crisis workers. A lot of master's clinicians and bachelor graduates come out of school, but they don't have a whole lot of background in crisis work because it's not taught at that level. So we do want to teach what are good practices there for improving services and safety. And then we also want to improve access to our crisis facilities by reducing the need for medical clearance and improving access for people with co-occurring mental health, STD, medical, and intellectual and developmental disability. And one of the most important things we asked in there is liability protections for mobile crisis teams and facilities, similar to what DCRs and other first responders have to kind of create that parity. Next slide. So just kind of wrap this all up, and the whole purpose of this presentation is to kind of lay out that what we're doing is improving and expanding access to our crisis services to divert people from using 911 to 988. Again, 12% of calls that go to 911 could be better served through our behavioral health system, but the other way around is not quite as there. It's only about 0.3, 0.5% of all calls need an active rescue that go to a 988 or regional crisis line. HCA services are largely funded through leveraging federal and state dollars. All of those mandates from the federal government and the state government follow down to the provider. So that dictates who provides the services, where they can provide the services, or what service standards are there. Those are largely already set. And then HCA has some flexibility through contracts by building off these mandates. So as long as we stay within those mandates, we can change some of them through statute, rule, et cetera, but we can control the distribution of state dollars directly, and we can also inform the distribution of Medicaid through different modeling practices, and we can also create programmatic standards and reporting requirements that can also change the way the system's going, just like the best practice manuals and data collection tools. So with that, I believe that's my last slide, and open it up to questions.
Matt, thank you so much. That was a whirlwind of information. I know you worked really hard on pulling this together for CRIS Committee, so thank you so much for the very comprehensive presentation. I'd like to open it up to CRIS Committee members for Q&A. Matt and the HCA team is here to answer your questions. And Jane actually had sent me a chat to contribute to some of the information that was shared. So Jane, if I could pick on you first, and then I'll call on Dylan.
Sure, thanks. So Matt did a great job, and I do need to, so with passage of, many of you have heard me talk about passage of House Bill 1688 during the 2022 session, and the requirement for private health plans to cover behavioral health emergency services that are provided in settings other than hospital emergency departments. And one of those is mobile crisis response. And so there has been a lot of work going on. And I just wanted to point out that where Matt had on the slide that mobile crisis response teams are funded by Medicaid and public funds, with implementation of 1688, there'll actually be some private health insurance funds going into the system. And what we're working really hard to try to do is to not recreate the wheel, but build on the current system. So basically leverage the contracts that the behavioral health, that the BHASOs have with providers. And it's like having the BHASO be sort of a provider network. Then they go out and they get the contracts with the health insurers. The health insurers, they'll bill the health insurers. The health insurers will pay them, and then they'll turn around and pay the mobile crisis response teams the same way they're paid now. So the whole idea is, how do we take the infrastructure that's in place and use it in such a way that we can get new revenue into the crisis system? So I just wanted to.
Thanks so much for adding that, Jane. That's helpful information to augment what we heard. Dylan.
Hi, and thanks, Matt, for all that information. Something that you highlighted was the education piece for folks coming out of undergraduate or even graduate level programs. And so just a thought to put out there is what it might take to modify some of these training programs to make sure that folks are more ready to this. Like every single mental health provider is going to encounter a crisis at some point, maybe not as regularly as a first responder. So that's just something I'm thinking of. And at least UW School of Social Work, I know that was something they were revamping some of their curriculum in the past few years or something like that. But my question is though, Matt, you mentioned 12% a stat for the number of calls that through 911 that might be better served as a mental health thing. I'm curious about how that was being defined. How did they know that would have been a better one for mental health? Which also brings the question for me around, for first responders, what training are they going through to determine if a mental health provider or a mobile crisis response team might be needed there? We talked about standardizing training for the mobile crisis response teams, but what standard training is going for those first responders?
So Dylan, two questions, and it sounds like, and then we also make note of your comment. How did Matt and team arrive at that 12% statistic? And then second, maybe some of our CRIS committee members that are with first responders can help answer your second question, if I got it right, which is what kind of training are first responders getting, or maybe in the triage to determine who goes out.
Yeah. How does someone know that, hey, we might need someone from the mental health crisis team out here instead of,
Okay.
or because, yeah, before it kind of gets to that level, how do they find that part out?
All right, so maybe some of our CRIS committee members who might have the answers, so I can think about that. In the meantime, Matt, you mind answering the question about 12%?
Yeah, first of all, really love your comment about the need for education changes. Totally agree on that. The 12% came from a Seattle Times article, and from the data source from that was really kind of an impression. A look back through a lot of calls and the outcomes of those calls. So it's really kind of limited to the Seattle area and that particular PSAP, but it serves as kind of just an illustrative point that a lot of people call 911 when they'd be better served through different systems. It's not it's not like 50% of the time, it's not a really, really high percentage of the time, but it is enough that if we were able to divert them to a different service, they would be able to be served in a more effective manner. And then for the second question, it really varies across the state from our research. I'll let some of our first responders jump in here and say that, but I can just tell you that it also varies quite a bit based on every region's practice and resources.
Do any of our other CRIS committee members have anything to add to that? Yeah, Kimberly.
Thanks. I was hoping that at least Chief Harding might speak to this, but I'll jump in and do my best at a response. I think the training in most parts of the state about how to utilize crisis teams in other parts of the behavioral health system is done through CIT training, whereas was just indicated by Matt, varies pretty widely between regions. The point that I want to make that I think is really important for the committee to hear, I'm not sure that police and fire need more training about how to call in teams that would be more appropriate than a first response. I think the problem that's endemic throughout the state is that they very much want to call teams and the teams aren't available. When teams won't come out into the field, or teams take hours and hours to come, or teams are just suggesting that people get transferred to the emergency room to get any sort of attention, it's really not a training issue, but more of a resource issue. And I see the chief has his hand up, and I bet he can elaborate this better than I can. Thank you.
Chief Harding.
Yeah, Kim's right on track. I mean, it's we can make an assessment pretty quickly that a situation we're dealing with may not have any law enforcement need. It's very quickly ascertained that it's not a criminal matter, that there's some other issue at hand. And when that's the case, our dilemma is what resource is available? Who can we call? So if there's a crisis team that we can reach out to, we will. If there isn't, then other solutions or no solution often is the only alternative left. So I think Kim's exactly right. We need more teams, and I think everyone acknowledges that, to bring the right resources to situations that we sometimes wind up being involved in, but probably are not the right resource for that particular need.
Thank you. I have a couple questions in the chat, but I want to see if Jessica has anything to add to this, and then I'll go to the chat questions. Jessica?
Thanks, Jamie. So in our region, our crisis team works with a lot of different law enforcement jurisdictions, both as co-responders and as just our kind of generic crisis team that interacts with law enforcement as well. And what we found is a lot of times that determination about when to call for behavioral health support, when to make that referral in the moment, when to maybe make that referral later, is really dependent on the working relationship and the familiarity and the kind of trust that's built up in that local kind of regional way. So we have some law enforcement agencies in our area that are very specific about what they will and will not participate in, and they will refer to us and they will leave. And we have other law enforcement jurisdictions that they want to have more of a conversation about what's going on and maybe kind of game plan it or problem solve our joint approach. And then we have other law enforcement agencies where we actually have co-responders embedded with them, and that that communication is way more seamless, and it becomes a lot faster response. Honestly, we're able to provide a faster, more appropriate behavioral health response because those channels for kind of going, oh, this is something that our co-responders handle, or this is something that we need to be there and provide support for the co-responders, but we don't have to take center stage, or we can leave and we're going to call and have someone follow up with them. And we've found that that's just gotten, it's gotten smoother as time has gone on.
Thank you, Jessica. And actually, that's a beautiful segue into our discussion we're going to have after the break. I know many of you are probably eager to talk about these considerations, and so I want to do a deeper dive into that. Before that, though, we do have a couple of clarifying questions, so I want to get through those, and then I do want to give you a break. We'll probably have to shorten it a little bit over what I promised you because we are getting short on time, and I want to make sure we have lots of time for our discussion, or as much time as possible for our discussion. So a couple of questions. And Matt, you can let us know if these are ones to answer now or to get back to folks on. But can HCA tell us how much money they've gotten so far for mobile crisis response teams, and some breakdown on percentages of the sources? Has most of it come out of Trueblood? So that's the first question.
Yeah, I can give you on a generic team, outside of any Trueblood funding, 30% of the funding for mobile crisis is Medicaid. In our current models. That's to ensure that our mobile crisis team can serve everybody. Trueblood funding kind of varies from region to region, and mobile crisis is kind of moving out of the Trueblood settlement as a whole and falling more into the 988 program. So that funding, I don't really have a good answer on that one. I can circle back on.
Okay, that's a good one to circle back on. And then why are only 0.3% of calls to phone centers going to active rescue? Is it because people naturally call 911 even in a behavioral health crisis because they didn't know of, sorry, RCL, I'm getting an acronym here, but I'm not sure. it's not coming off the top of my head, and now 988. Oh, regional crisis.
Regional crisis line, yep.
Sorry.
Oh, we can acronym ourselves to death here. Yeah. To be honest, I don't know exactly why a very small amount. I think it's because a lot of people who access regional crisis lines are calling them deliberately for support. It could also be part of their treatment plan or crisis plan to call a regional crisis line before escalating to any other needs. On the 988 side, they put an emphasis on resolving things on the phone. So they take the time to work through a safety plan and de-escalate the person. So a lot of times the active rescue is not necessary given enough time to work through them in those particular situations. But I would probably guess that a lot of people who are in emergency need would call 911. That's still, if I think of an emergency, I'm gonna call 911 over anything else. That's what's just programmed in my head. It's probably a good thing though.
All right, I'm not seeing any other questions in the chat, and I do want to give CRIS committee members a little breather before we start our discussion. So Matt, will you be staying on with us during the discussion in case there are any other clarifying questions that come up?
Absolutely.
Okay. All right, and CRIS committee members also, HCA is super responsive. So if you think of other questions that come to you later, I think sending them to Nicola will relay those. I know there's probably so much information and lots to process, so we'll have an opportunity to answer questions that come up for you later. It's 5:04. I apologize for shortening our break, but again, I want to make sure we have lots of time to talk. So can I ask everyone to be back on camera at 5:10 p.m. And we'll dive into our discussion. See you in a few minutes. Okay, welcome back, everyone. Give folks a moment to get settled and turn on their cameras.
Jamie, did you send those discussion questions?
Yes.
Okay, thank you.
Okay. Great. So Representative Orwell, I think you're going to set up our discussion before I turn it over to you. I just want to reiterate our objectives for our conversation today. We've been talking a lot, and we actually started talking a little bit about it in our previous Q&A session, about what collaboration between behavioral health and first responders, specifically emergency medical services, fire, and in some cases law enforcement, should look like, or if at all. And what we want to do today is start exploring your perspectives as CRIS committee members, your professional experiences. We have folks on our committee representing lived experience. We also have folks on the committee representing professions, but who also have lived experience. So we're looking for your perspectives today on these considerations related to collaboration between behavioral health and first responders. And then we want to spend a little time identifying areas of common ground, because there may be some coming out of this discussion, and also starting to sort out where we still have, or where we have areas of divergent perspectives. And that can be where we can have some continued conversations. And with that in mind, agree on next steps for offering some guidance to the steering committee. And to sort of set that up for you, I'd like to turn it over to Representative Orwell, who's going to offer a little bit of context for our conversation. Representative Orwell. I think you're on mute there.
Oh, good. Can you
Awesome.
hear me now?
Thank you.
Yeah, no, I just want to say hello and thank everyone for being here. And I can't believe it was like our 11th meeting. So that's incredible. And I appreciate all the presentations that we've had to kind of build up to this conversation. And I do think with any major system change is that opportunity to think about our system and what it should look like and what partnerships can look like. And, you know, these are big lifts and these are important conversations. And so, you know, I think really wanting to say, and I always think, I don't know, the Wizard of Oz, when someone calls 988, we want them to see a simple system, right? We have to deal with the complexities of the system, but what should they experience, that family member or that person that calls? And so I appreciate this dialogue. You know, I did a lot of focus groups over the summer with communities of color, and there's a lot of concern to call 911 and 988. So I think the conversation we're having is, how do we make sure everyone feels safe, and what does it look like, and how does it respond? And I know with the healthcare authority, there's no easy answers. I get that, but you know, how do we create that system and then figure out how to fund it and braid all those things? So I think today I'm excited to kind of listen and learn and hear the discussion.
Thanks, Representative Orwell. I'll just add a few things to that and then set up our discussion. It probably feels like a really long time ago, but about a year ago, I think it was, we were talking about how we center equity in our work on crisis response improvement. And this was a key theme that came up in those conversations. So we're approaching this conversation today to address what came up when we talked about equity last year. The steering committee will have some deliberations on what they hear from you. And so as they develop recommendations about if, when, and how mobile crisis response teams coordinate or collaborate with first responders. And so what we're going to aim for is agreeing on some next steps for providing guidance to the steering committee, which may include some further discussion on the areas where CRIS members diverge. So keep that in mind as we're having our conversation today. I do want to offer us a little bit of framing before we dive in. You've heard HCA, Matt, talk about what they're implementing, which are mobile crisis response teams that do not include first responders as members, but they do coordinate with first responders. You may have heard Representative Orwell I'm sure you've heard her reference House Bill 1134, which includes rapid response teams that do include first responders in some cases, but not law enforcement. And we know that 911 receives many behavioral health crisis calls and coordinates dispatch. So given that there's a lot of different definitions here, and we don't know yet what the specific role of first responders will be in relation to a crisis response team, I'm going to ask that we be agnostic to that today and discuss considerations when, if, when, and how behavioral health and first responders collaborate. And as a reminder, by first responders, of course, we mean emergency medical services, fire, and law enforcement. So I'm going to have, I think Chloe's got the initial two discussion questions. I'm going to have us tackle these together because I'm not sure. Based on what I've heard from you so far, I'm guessing you don't necessarily want to compartmentalize these. So 2 questions I want you to mull over and share about. And I also want to remind you that you are welcome to put your thoughts in the chat if you don't feel, if you feel like that you express yourself better or feel more comfortable writing it rather than speaking it. Please do let me know also if you'd prefer that I not say that it's you who's saying it, if that would be your preference. The 2 questions for consideration are: under what, if any, conditions would it be appropriate to engage first responders? And number 2 is, based on your personal and or professional experience and knowledge, what are some considerations around collaboration between behavioral health and first responders in a crisis? I also want to add, I got a note from, a clarifying note from Dylan, that when he was asking the question, or not asking the question, but offering the comment about, asking the question about first responders needing more training, he wanted to clarify that he wasn't implying that they need more training, but rather highlighting the need to better understand each side to streamline the process. And he adds that that was well stated by Jessica when they showed their example of what was working well. So wanted to just put that out there. So why don't you mull these questions? I'm actually gonna put them in the chat too, so we can take the slides down. Or actually, Chloe, would you put them in the chat to everyone? That way we can take the slides down and look at folks. All right, so under what conditions, if any, would it be appropriate to engage first responders? And based on your personal and or professional experience and knowledge, what are some considerations when around collaboration between behavioral health and first responders? Anyone want to kick it off? Jen.
Hi, can I just ask for clarification, or maybe we can level set around?
Yeah, please.
First responders.
Yeah. Oh, sorry. Are you saying you say that again?
Can we level set or like clarify what we mean by first responders? Like, does everyone have the same understanding of what we mean by that when we say that?
Well, I've been coached to say emergency medical services, fire, and law enforcement. It sounds like we could use a little more detail there. Does anyone have anything to add to answer Jen's question? Betsy, I know we sent out some definitions. Do you want to, can you, is there anything I missed there?
That's it,
Okay.
Jamie. We have
Okay.
that. Yeah.
Jen, what do you think? Is there something missing for you there?
Well, I just want to make sure like the potential medical expertise that comes in with a firefighter who can be trained as an EMT or a paramedic gets represented there. And I'm not sure if that is well understood with the group.
Okay, so when we say fire, maybe that's not clear to everyone who maybe has not interacted with fire or doesn't have that expertise that it's.
I'm not sure that everyone necessarily understands that most fire calls are actually related to health issues and not, even though in Seattle we had 30 boats on fire this morning and there were lots of firefighters.
It was an unusual day for Seattle firefighters. I think that's right. Okay, so that's an excellent point that Jen makes. When we're referring to fire, that there's in that group of first responders, there's an acknowledgement that there is medical training and that firefighters do offer emergency medical services type supports when they come out. Kashi.
I appreciate that clarifying question because I had the same thought in my brain that my answer to that question is different based on those different groups of first responders. There's different reasons to engage with EMS in my opinion, than there are to engage with law enforcement. Like under what conditions, if any, changes. So I'm struggling with lumping all of first responders into one category. So Jen, I appreciate the question.
Well, and along those lines, that's also a good clarification. When you think about that first question, it is completely appropriate to have a response such as, under these conditions, I think it would be appropriate to have EMS or fire involved, but not law enforcement. So you're welcome to answer that question. Oh, Betsy, sorry, are you referring to the slide where we talk about what we know now about?
Yeah, yes. So
Okay.
just thinking about
Thank
to
you for that
frame up the
reminder.
conversation. Yeah, that might be that was a level setting where, and maybe you'll share that slide, Jamie, and folks can see how
I forgot about that. That's right. I think you were anticipating that question. So Chloe, can you put that slide? I think HCA put this together for Betsy to review. There we go. Okay. Betsy, do you want to walk folks through this?
Sure. And, I might call Matt Gower since he developed this slide, but the purpose of this slide is for us to look at the three types of response. And we think, and, we're talking about first responders here, and here's kind of how we've defined it with HCA's help. And then on the right-hand side, there's mobile crisis. And the space we're occupying right now is the co-responder space and what that collaboration looks like. Matt, do you want to say anything about this slide? And again, the intent was for us to just be clear about the definitions so that we could engage in this conversation.
Yeah, this slide is just kind of an attempt to tease out the rough three categories of response. There's always overlap everywhere, but just to highlight that the three different types of first responder, fire and EMS often get lumped together because, as noted, fire departments often provide more medical assistance than they do firefighting. And then law enforcement is definitely unique in that category. And then highlighting that kind of co-responder is, we kind of see it differently from first responders, which are going out for a specific role with maybe just medical personnel, whereas co-responders often respond with either behavioral health professional, some sort of social service professional, or even paraprofessionals like peers and case managers. And then of course, mobile crisis, which we talked about a lot. So this is an attempt to kind of frame the discussion around those three categories. And then within the first responders, there are different types of responders, and wanted to hear feedback on which role they could play in this response system.
Thank you so much, Matt, and thanks for preparing that. I imagine this might be a little hard for some people to see on their screens. So would it be possible to also add this to our content on the website? I think that would be really helpful for people to be able to reference that. I see a couple hands up. So I'm going to call on Anna and then Kashi. Anna.
So Jamie, I had a question. You had clarified something about what Matt said with first responders and training, and you had said that he didn't imply that they're not trained, but that kind of threw me off, because why shouldn't we question whether or not they're properly trained? I mean, isn't that something we want to make sure of, that they are properly trained to deal with crisis response? And so I'm just kind of questioning why that had to be clarified.
That was from Dylan. I think he was just sharing the point he was trying to make, because I think he worried that it might have been misunderstood. But I respect and appreciate your comment, which is that it is, if I'm hearing you correctly, Anna, very reasonable and probably wise for us to question or ensure that first responders are trained.
Absolutely.
Okay, thanks for that point. All right, Kashi, and then Dylan, and then Jen. Kashi.
I saw Dylan's hand go up. Do you want to respond to that? Sorry.
Yeah, I can just run real quick. So I think what Jamie already stated there, and that additional clarification, I think we all have room to grow and train and get better at what we're doing. And this is part of the reason why we're doing all of this. And yeah, so I wasn't trying to, I guess what I was trying to say is I'm not trying to minimize any of the training expertise that anyone is bringing to the table, and just highlight the fact that I think we're just really trying to, again, one of the things is streamlining that communication and getting better about communicating with each other.
Thanks for jumping in there, Dylan. Kashi.
Thank you. My question was actually related to that slide. Sorry, right as it came down.
I just asked her to take it down. Okay, Chloe, you mind popping it back up again?
Sorry.
Sorry,
In
Chloe.
the middle column on co-response, that bottom cell for SAMHSA's best practice says no recommendation on co-response model. Is that a passive, like, lack of a recommendation, or is that an active recommendation against co-response in favor of mobile crisis response?
Matt, are you able to jump in and answer that one?
Yeah, can you say that again? Sorry.
Yeah, is the fact that it says no recommendation on co-response model in SAMHSA's best practice, is that a passive lack of a recommendation in their best practice, or is that an active recommendation against co-response in favor of mobile crisis?
It's a passive no recommendation. They don't address co-response in that model besides recommending coordinating with them. The only pieces in there around co-response, as we define it, because there's not a standard definition around the country necessarily, would be possibly using emergency services in rural areas for mobile crisis response, kind of like the Oklahoma model of going out with an iPad type thing. That's mentioned in there as a response for rural, but overall it's pretty silent on co-response in general.
Thank you.
Thanks, Kashi. Other comments? I'm going to check the chat here. Jen.
Thanks. I just wanted to reply to this kind of local conversation we're having here around these issues. So with regard to that last piece, that SAMHSA best practice, I think it's important for people to understand that SAMHSA is largely giving best practice about the system that they're commenting on, which is the behavioral health crisis delivery system. They don't have as much to say about the emergency response system as it relates to behavioral health, because that's not the system that they're primarily engaged in kind of providing funding for and oversight. So I just wanted to just put that additional context in there. And then, Matt, you are such an encyclopedia and have created so many amazing resources to help people understand the system. I think helping people understand like the training that people do and don't get, it's a very high level, but like, the understanding that, many law enforcement do get CIT training, 40 hours of crisis intervention training. Fire and EMS currently don't really get much of any training at all. There's no equivalent for fire and EMS, despite the fact that they're more often going out to these calls. Behavioral health providers in the field often get almost no training on how to be crisis responders. So I think that's complex. That's a really important issue that I really hope Rep. Orwell's bill can really help us grapple with.
Okay, I see a bunch of hands up. I also see a comment here in the chat. Though SAMHSA does not focus on co-responders, they are the national experts on behavioral health. All right, I see Jessica and then Chief Harding.
Thank you. So I wanted to just directly address that first question. From my perspective, like I said, as a manager of a crisis team that does co-response and works with law enforcement quite a bit. The first thing that comes to my mind is situations in which it would be unsafe for crisis responders to respond in the community without support from law enforcement. Because in practice, what happens if there is a situation where there is a referral, a request from the community to go and meet with someone in the place that they're in, and there are safety concerns in that situation, not necessarily related to the person, but it could be related to the person, it could be related to other people in that situation. If there are safety considerations that we can't manage, we cannot send our crisis staff. I have bachelor's level staff, I have peers, I have master's level staff. They do not have the training or the experience. And frankly, it's not in the job description for them to put themselves in physical danger, put themselves in situations where they may have to defend themselves physically, put hands on someone, be in that kind of situation. And I want my team to be able to respond when there is a need, even if there are safety considerations. And partnering with law enforcement and with fire and EMS allows us to go into situations in the community that maybe we wouldn't be able to otherwise. It's also allowed us to go to situations in the community where in the past, historically, we probably would have told the referent, you're going to need to get them to the ER, and then we can see them in a safe location. So that partnership and that work together has allowed us to provide care in situations where otherwise we would have had to say, hey, I'm sorry, we can't go do that.
Thanks, Jessica. Chief Harding.
I was originally just going to address some of the training question. All law enforcement officers in the state of Washington do receive crisis intervention training every year. And the new standard in the academy is a 40-hour training. And most, I would say many agencies in the state have moved to that as a standard for their officers in the field. So for instance, our department, 40 hours is a goal for every officer we have. I think that would be a good standard. However, it is not, that training doesn't replace the need for crisis workers who have far more training and experience in those situations. And I think, Jessica said it very well. The question, the bright line is if there's an element of danger, an unsafe situation, that is when law enforcement can be deployed because that is our training. That is the primary element of training that no one else gets, that we do have. And we're very good in most of those situations in providing safety and security. So to remove us entirely, I don't think can happen. If you were to ask most field response crisis workers, let them inform that question, because they're the ones on the front line dealing with situations, and they need to be able to do that in a way that their safety is assured.
Chief Harding, I have a clarifying question on your point about training. Is that 40 hours a year or 40 hours at one time?
So it's 8 hours every year.
Okay.
It's 40 hours, but that we try to repeat that within every 3 years.
Okay, and I don't want to get us too in the details here, but going back to Anna's point earlier on, I think we might at some point want to have a deeper conversation about what that training looks like and what it should look like if we can dive into that. Okay, I see Kim and then Anna, and then I'm going to go to the chat here. Kim?
Hi, thanks. So I was thinking initially when these questions were raised about a lot of the conversations I've heard or been witness to with families who've lost loved ones to police shootings through coalition around police accountability in Washington. And a lot of the stories they tell have to do with arrival of an officer on the scene in and of itself, right, can be an escalating event. And just both the fear of contacting the police that Representative Orwell mentioned, and also just the fact that, an officer arriving can have a really significant effect on what's happening. I was thinking about that, but and then also hearing Jessica said, which is a great point, that in order to facilitate this contact, you do need everyone to feel safe. And I guess what I'm thinking is it would, right now, the presumption we start with is that it's unsafe and the police go first. And then the analysis is, can we also add the behavioral health support? And how do we get to a place where we flip that? So the presumption is it's safe and we're starting with behavioral health support. And then the analysis is there actually an identifiable safety and security risk, right? That then we need to call the police. I feel like we have to flip that.
So Kim, just to probe your point a little more, is your experience, your observation that we're over relying on first response and that's the thought to flip it?
Yeah, I guess I don't know exactly what the data is showing now in Washington, but I think, traditionally, most places, the presumption is the police are getting the call and are responding. And if we're lucky, we have a co-response team. If we're lucky, there's maybe someone diverts it to mobile crisis response. But we're not starting in the non-law enforcement first responder land. We are starting in that land, and then if we're lucky, adding behavioral health response as a support. And can we switch it so that 988 leads to behavioral health, and then there's a real look at whether there's actually a security threat such that we want the officers and we need them.
Okay, so whether it's mindset or training or resources or capacity, you'd like to see us figure that out and be able to flip that calculus. Great, okay. I'm going to take Anna, then I'm going to go to the chat, and then I'll come back to the other hands. Anna?
So before I continue, I just want to add a disclaimer that I don't think that police should be completely removed from the situation. I just want to clarify that. I do want to say that as somebody that gets a lot of feedback from behavioral health consumers, especially after 988 was initially implemented, that as long as communities are, as long as there's no assurance that law enforcement is like the absolute last, sorry, I just lost my words, but basically, as long as people aren't assured that other steps will be taken before law enforcement steps in, there are going to be people from BIPOC communities and LGBTQ communities who will refuse to call 988. And so again, I don't think the mentality here, especially, is that cops should be completely removed out of the situation. I think the mentality is that should be an extreme case. And also there's a lot of talk about, people feeling endangered. I think there really needs to be more of a definition of what that is, because that's very subjective. And again, not trying to say anyone is, in any particular way. I'm just saying that, it is a fact that we have all grown up in a white supremacist society, in a white supremacist system. And so there is this unfortunate, this unfortunate perception from a lot of people that people of color could be more dangerous. And again, I'm not saying that people are racist. I'm just saying that this is the system that we've grown up in. And so I really think that, sense of danger needs to be more defined than, and not be left to, subjectivity. So that's just what I wanted to say.
Thank you, Anna. I heard a few things in there, and you're echoed quite a bit in the chat, so I'm going to share that as well. But some takeaways from what you said. First of all, we need to be clear what we mean by unsafe. And also, it sounds like, I think I heard you say that you're talking about a system that's existed for people for a long time, for their whole lives. And so it's going to take a lot of work to change that and that fear, if at all. Did I hear that right?
Yes. And then I just, again, long day. Cops should be, police should be last resort.
Last resort.
That's what I'm trying to say. Yes.
Thank you. Yes. And I'm going to just, I got some chats. Here's from Puck, who's mentioned this before. My community currently doesn't feel safe calling 988 because there is risk of law enforcement involvement. That includes trans folks, BIPOC folks, immigrants. So Anna very much echoed. And some thoughts here from Bipasha also. She echoes what Jessica said when behavioral health professional determines they are needed. Sometimes they feel unsafe. And then reflecting on Diana Cortez Yanes, who we honored at the beginning of our meeting today, she came to many lived experience subcommittee meetings and shared that she's concerned about the Hispanic community being afraid the police will come. And she did not call for her Black nephew thinking that cops may come. So this is an experience that a lot of people in our communities have had, and this is what Anna said is echoed here in the chat by Puck and Bipasha. So thank you everyone for offering that. I will go back to our raised hands and then come back to the chat again. So Representative Orwell and then Jen.
Thank you. And this is such an important conversation. And, you know, just with the focus groups we held, really, the message seems so clear not to have law enforcement part of the core teams, and not that they aren't a backup. One of the things that struck me, though, with fire and EMS is they have a lot of comfort in securing settings. And so, you know, I do think they should be looked on between the medical and securing, you know, that may be some extra support for a behavioral health professional. But again, I just, you know, if we create a system where people don't feel safe calling, I just feel like we've kind of defeated our purpose. So I'm hoping that we will have law enforcement as a last resort.
Thanks, Representative Orwell. I'll take Jen and then I'll go back to the chat and then come back to Chief Harding. Jen?
I just wanted to add something that I didn't realize until I had the exposure of riding along with several teams across the state, co-response teams, fire and police. And it's a statistic that I had forgotten in a lot of my work, which is that people with serious mental illness are far more likely to be victims of crime than they are the perpetrators of crime. So the reason that's interesting to me is it suddenly slammed me in the face when I went on a lot of these police-based co-response calls that were people with serious mental illness calling the police, calling 911 to get help with crimes that were being committed against them. So I just want to just put that out there, that I think that's kind of a pretty important situation where we would need a mixture of police and behavioral health professionals. I saw that time and time again on some of these calls.
Thanks for sharing that complexity and that observation. I certainly haven't had that experience of riding along, so I appreciate you sharing that. I'm going to go back to the chat briefly. From Marie, she indicated she had to file a complaint against the co-responder, an EMT that transported her child to the hospital for playing a game on my adult child after their suicide attempt. I spoke with fire department chief regarding the awful conduct of these emergency personnel and wanted him to consider better training so this would not happen to another community member. And Maria also wanted us to know that her child is Black, LGBTQ+, and an Army veteran. So thank you, Marie, for sharing that in the chat. And then here's from Bihasha, another lived experience member said, please summarize in your own way. This member works in Spokane as a housing services peer, has lived experience of suicide and of crisis response, both as a recipient and professionally as a peer. Officers in protective gear, designated crisis responders in plain clothes come as part of the response. It doesn't help the situation when people see these officers. A couple of cases where, apologies, this chat is being, there we go. Couple of cases where the officer present would intervene and override the peer and take the person to jail due to an outstanding warrant, which leads to relapse and decompensation. They just lost their faith in the system and lost all hope. Makes it hard for this person to support the person, and he feels their frustration. If you're in a mental health crisis, you should not end up in jail. So thank you, Bipasha, for sharing that story from lived experience subcommittee member. Chief Harding.
I just was hoping Representative Orwell would clarify. Are you suggesting that fire departments or their personnel would provide security at scenes?
No, what I was saying is some of the models of co-responder teams are fire, EMS going out with behavioral health. And what I was saying is they seem much more comfortable than a lot of people that work in mental health going to a scene, not knowing what to expect. And so they always say, yeah, we walk into a scene and I know that they have a great connection to law enforcement, that if it's not safe, that they have a way of contacting law enforcement. So I just feel like they seem, when I've gone out with co-responder teams, that they're just much more comfortable walking into an unknown situation. But that's just my observation.
Thank you.
Chief Harding, did you have any feedback on that, or is it a more clarifying question?
No, I just wanted to make sure that we weren't trying to assign the responsibility of scene security or safety to fire personnel, because every fire person that I've spoken to would not accept that role.
Got it. Got it. Thanks, Chief Harding. Okay, I see Kashi, and then I've got some comments in the chat. Kashi.
In preparation for this meeting, I looked for the SAMHSA best practice for crisis system for children and youth. And I think, Matt, I appreciate that much of your context was provided about the system in general. And I do want to take a minute to talk about youth. SAMHSA best practice clearly says law enforcement should be avoided at all costs unless absolutely necessary to respond for all of the reasons we've been talking about, right? The presence of law enforcement can be triggering and increase the risk at the situation. It may prevent kids and families from calling 988 if there's concerns. And so I just wanted to enter into the conversation that we should potentially be thinking about the youth system as separate from the adult system, and the role of law enforcement in the youth system should be minimized as much as possible for and echoing what many have talked about, right? It will the other thing I wanted to mention, especially in response to what Jen shared about the experience of riding along, is I don't think anyone is, I'll speak for myself. I don't think I'm saying that law enforcement shouldn't respond to criminal calls, right? That's the role of law enforcement. But if you are calling 988 and you are in a mental health crisis, you should get a mental health professional. Thank you.
Thanks, Kashi. And I'm also reflecting back on Anna's comments about getting better definition about what constitutes unsafe. It sounds like also being clear about what is a mental health or behavioral health crisis versus a law enforcement call, since as we just noted in here, someone had the experience of having law enforcement involved because they had an outstanding warrant. I'm going to take Kimberly, and then I want to share a comment from an HCA team member in the chat that I think will be helpful. Kimberly.
Great. Thank you very much. I think some of this conversation is difficult because our assignment as CRIS committee members is to really focus on the 988 system. But one of the we keep coming against is that crisis. Again, our charge here is 988, but it's an unfortunate fact that so many people needing crisis services are using the 911 system because that's the response that they think is more appropriate to their needs. So we're in this funny spot here as CRIS committee members that we're here to talk about 988, but the reality is that I would say most crisis calls in Washington state are handled through 911. So the question for me isn't, are first responders appropriate in crisis calls? They're going to be there because the 911 system is being so heavily relied on. I think that the more important question for me is, how can we improve 911 response? So I just would like to comment that I'd like to move away from a discussion of yes or no. It's not a binary choice of should first responders be here or not. That decision was made long ago with the cultural shift towards 911 as being a quick response to all societal problems. People use 911 for a whole range of services, including crisis response. That's not going to change. For me, the key question is, what kind of training are we giving to our first responders? And I love it so much that that's come up as a conversation point. And it's not enough to say that anyone needs more. If we do think that it's incumbent on us to, for example, train fire and EMS and behavioral health because they're not getting that requirement now, who's going to pay, right? How will that be designed and compensated? So I really appreciate the training conversation. And I'd also add that the co-response piece to me has always been, since police and fire are responding to these calls anyway, how can we make that response more effective, humane, trauma-informed, patient-centered, doing the same thing again and again and sending the first responder that answers a call to a scene? That's worked for a number of years, but again, in recognition to the fact that first responders will continue to respond to 911 requests for help, what can we do to improve that response through training and shared standards for co-response? Thanks very much.
Thanks for that point, Kimberly. And that actually suggests, Jen Stuber also asked that we put the questions back up on the screen to remind ourselves what we're answering here today. So thank you for raising that. Chloe, can you put those questions back up on the screen? I think Kimberly was taking us primarily to that second question, which is, what are some considerations with respect to collaboration between behavioral health and first responders in a crisis? And we're saying collaboration, but I think we're talking about a range of situations. As I said, I wanted to be agnostic to how it happens that first response is involved, but I hear Kimberly saying that people are calling 911. I see and hear Carrie reminded us that 988 just started, so that's also why people are calling 911. But what are the considerations when that happens, if inevitably some first responders or law enforcement are coming out to a crisis? Okay, lots of hands here. I'll take Michelle and then Carrie and then Jen, and then I'll go into the chat.
Well, thanks. I was going to echo Carrie's comment that I think we've had, and in response to Kimberly's comment, like we've had an over-reliance. It was built that way because we did not have a well-known number for mental health response. And that's the whole intention behind 988, is to divert calls that have been using the 911 system to 988. Clearly, based on this conversation, there's so much more we need to do in partnership with those with lived experience and with communities, especially communities of color, to make sure that's a trusted experience. But I think the goal, and I think the goal under 1477 is to divert some of the calls from 988 and transfer them, from 911 to 988 and to behavioral health clinical response.
Thanks, Michelle. There's a question in here. These questions aren't specific to 988, which is why the answers of when police respond needs to be broader. Is that what we're looking for, just 988? And Betsy, please correct me if I have this wrong, but I believe we frame these questions to be intentionally broader since we're talking more broadly about the crisis response system. Is that accurate? Okay, I didn't misspeak. Awesome. Okay, Jen.
Sorry, that was just my, I was just wanting to respond to Kashi. Like, I understood these questions broader than just 988. So that's why when I made the comment that if someone calls 911 with a behavioral health issue, but they're really calling about a crime or that's happening or in progress, like that would be a situation that I would love to have a co-responder present, like a co-response situation, because you've got somebody who is in a situation that they don't feel safe, which is very common with people with serious mental illness, where they don't feel safe. They're a very vulnerable population. That it would be ideal to me you'd have to have a first responder. They're calling 911, but these questions to me are not specific to 988.
Yeah, I think you and I understood that the same way, Jen. Thanks. There's a comment in the chat from Sherry Wiley with HCA. Ron Bruno of CIT International spoke at the Crisis Jam this week. He said to keep EMS, fire, and crisis teams separate, not embedded, so that EMS, emergency medical services, and fire can leave the scene and the crisis team can stay and work with the person as long as it takes. So that's very germane to the conversation here. I want to share a story that Bipasha passed along. Sarah got a call from her husband because their 16-year-old daughter made a suicide gesture. Not the first time a suicide ideation and attempt. They called 911 first, but then hung up when they remembered that there's a 988 line. They got something in Spanish. While waiting, they got a call back from 911 and they sent the police over, found her just in time before walking into the street with a hammer. Police arrested her in handcuffs, and then she got admitted to a hospital, which was not the outcome they were looking for. Let's see, anything else in the chat? I think I've gotten everything. If I missed your chat, I apologize. There's a lot in here, so please resend it to me if I missed it. All right, and just a reminder, folks, this is just the CRIS Committee talking today. I do see chats and hands raised from our community members and guests, but I'm not able to take your comments today. I need to focus on hearing from CRIS Committee members, so apologize for that. Jen.
Sorry, I'm just bringing up other examples that I saw in some of these ride-alongs that I think it's in the situation of the grave disability category where people aren't sure if someone is going to be able to maintain, they're going to be okay in the community, whether they need harm to self or potentially to others. The situation that it's, there's a limited availability of DCRs to go out into community-based settings. That necessitates law enforcement getting called in a lot to situations that maybe wouldn't necessarily require it, but it's the way that our statute is written. I mean, people on this call can speak much more deeply about this than I can, but it's just something that I observe that police, because of their ability, their legal authority to detain, get called in. And I'm not saying that's right or wrong. I'm just saying that's a reality we have to look at.
Again, Jen, thanks for sharing your observations on those ride-alongs. Comment from Kashi here. Jen's comment in response to me was helpful because that does make me see a role for co-response, which is in response to actual 911 issues where there's also mental health issue involved. Calls to 988, especially for youth, should not get law enforcement response unless significant criminal or safety concerns. They should get mobile crisis. And I think I'm highlighting that significant criminal and safety concern and going back to Anna's earlier point about getting clearer on that definition. I also want to remind folks, or actually say it because I didn't say it earlier because our timeline's a little bit in flux, but we are intending to focus on youth, have the similar discussion about youth at next month's CRIS Committee meeting, and Kashi will be checking in with you directly to talk about how we do that. So expect a call or an email. Other comments or feedback? Oh, Jan.
Hi, when I think about crisis response, I think about it in terms of this continuum of services where the mobile response is determined by the level of risk. So there are situations where it is appropriate where you have a mobile response team that is dispatched or a co-responder team that's dispatched. But there are also situations from the get-go because of the information you have from the referral source or because of the information you may have historically on a person or just their current behavior and what a third party may be describing, where law enforcement is more the appropriate response. I don't think that it's pretty common that even if DCRs respond to a high-risk situation, that they themselves will contact law enforcement to team with them on that outreach. So I think mobile response is really a continuum, and where we need to look at what criteria make sense for the type of response so that we can keep our staff safe in these types of crisis situations.
Thanks, Jan. Michelle.
Yeah, I just wanted to add to the conversation a little bit of context specifically around the idea that we're all working to try to divert calls that have been going to 911 to 988. As the three crisis 988 call centers, we've been doing a lot of work and facilitation has happened through HMA and others around mapping that relationship between 988 and 911 and the regional crisis lines. And then also at least a couple of the 988 crisis hubs have also been talking more deeply with their local 911 call centers. And we're really trying to understand each other's roles better, because also 911 staff are also asking for more training and clarification. But one of the things that's really important to understand is that the role of the 911 operator is to very, very quickly understand what's happening and make the best decision in the quickest amount of time about dispatching. Their job is to dispatch a resource. And so that's their orientation, and their, it's life safety, fire, medical, crime, those kind of things. For 988 and also the regional crisis lines, the purpose is assessment and crisis resolution. it's building rapport. It may end up being a conversation around life safety, but it's a very different orientation about what your experience and what the training is and the purpose of 911 and 988 and how this work is done. As we've talked about, there's crossover here. 911 or 988 could receive a call where there's imminent risk, suicidal ideation, access to that, a clear plan, danger to others. But we also know that statistically, I think Matt had talked about 0.3%. So usually ranging from 0.8 to 0.3%. So definitely less than 1% of calls that come into crisis lines do turn into an active rescue where 911 is involved. So it's important that we understand, and I think we're all agreeing that there are times where law enforcement or medical personnel are required in a situation. But the other component about this for 988 and regional crisis line staff as well is that we're trained to get consent and to, many times when we are bringing in 911, it's with the consent of the caller. Hey, we would like to have, EMS or, whatever the first responder to come out or a mobile crisis team. And so I just want to give that context that is the best practice and ideal that if I could speak for all 3 988 call centers, the experience that we're trying to have with the callers and that consent and connecting to resources, whatever the most appropriate ones are. And in a very small percentage, it really is the need for immediate, either, usually in our situations, it's not looking for armed, but it's looking for medical personnel that can show up. So I just want to give that context around, let's step back and know what the purpose and the training is for each of these 3-digit codes.
I really appreciate Jan and Michelle's comments here and helping us understand some of the distinctions between how 988 lines are working and the orientation. And, I think you framed that really well, where you were talking about the differences in what the mandate is or the experience of a 911 responder versus a 988 responder. So thank you for contextualizing that for us.
If I could just add one more quick
Please.
part. I also want to let you know that we understand the concerns from marginalized communities, particularly the Black community and Hispanic community, about the what could happen when law enforcement shows up. And so we're very aware of that as well, and get that and respect that we do have situations, and I think there's statistics on this where when law enforcement in particular shows up, the response may look very different depending on the race of the person they're riding up on. So I just wanted to make sure that that is also acknowledged, and that's true as well for transgender and basically communities that have been marginalized, and that's a real thing, and we acknowledge that as well.
Chuck used a phrase earlier in the chat, disproportionately impacted. So thank you for sharing that, Michelle. Pasha.
So I wanted to echo what Michelle just said. But before I go there, I just want to say, I think going forward, it would be helpful for us not to lump all first responders together. I think that's really important, and separate fire from EMS from police. The answer to when should we contact the police, I think that's basically the question at hand. For me as a crisis line worker, it depends on what person is calling for. I've got to meet my clients where they are. That's just like what Michelle said. I check with them and I ask. Some people are actually glad they're okay to call the police. And I'm like, all right, let's figure out how you can phrase your needs so you can get the help you want. There are some people though who don't know. For example, the immigrant community. They come with their own experiences from wherever they are about what law enforcement might do, or first responders. They may not even know. So us as crisis providers being able to answer their questions is very, very important. And then the last group is there are clients who are like, nope, not comfortable having the police come out. And I think I can safely say in the phone room these days, we try to dig really deep to see what else we can do to help that caller rather than telling them to call 911. But if absolutely nothing exists as often it does these days, we let them know how they might approach the call to 911 to get the best outcome possible. I hate doing that, but sometimes my hands are tied. I think Kristen would also agree that as a provider in a certain context for me and her, it's just frustrating when we don't have, and that's, I think the goal of this whole process is to figure out how do we create more responses that do not involve police, especially for people who don't want to engage with that system right now, because it's going to take a long time for us to build back trust among certain communities.
Thanks, Bipasha. I saw a lot of nodding heads to your comments, so I think those are appreciated. We are getting to kind of the last few minutes of our discussion time. This was clearly a thought-provoking conversation, because when we started this meeting, we had one person signed up to make public comment, and now we have 4 people signed up to make public comment. So I do need to preserve that time for comment. But I wanted to close out this discussion by asking each of you to reflect on what you heard today that sounds like maybe some common ground amongst CRIS committee members, and what you heard today that sounds like maybe needs some further discussion. Again, with the objective of providing some kind of guidance to the steering committee so they can make some recommendations around how to approach engagement with, I won't say first responders, because I've heard you. I think that sounds like common ground, that it's not appropriate to lump fire, EMS, and law enforcement as one group. So this may take some reflection, but does anyone have any initial thoughts on what you heard today that sounds like common ground? Thanks, Chloe. Oh, and I want to answer a question from Kashi here. Is this our only discussion on co-response first responder role aside from upcoming youth conversation? No, actually, I'm going to propose something to you, because I don't think just an hour on this is enough, and I can tell that we've clearly got some places where we need to do some work. So let me hear from folks if you've heard anything that sounds like. Why don't I just focus the question? Anything that you feel like we need to do more conversation on specifically that you heard today? Okay, I'm seeing Dylan, considerations on the differences of perception. Yes. Dylan says it hasn't been stated explicitly yet, but there are considerations on public media perception of fire, EMS, and law enforcement. Yes. I think that's consistent with also some of our conversations about people's experiences and perceptions. Chief Harding and then Kashi.
Just I think an area where we could have common ground would be to focus on training with mental health considerations and law enforcement. If there are those extreme instances where law enforcement is required to respond, then it would be good to have a better common ground for behavioral health experts to have some trust in the training we've received, to provide more training to us, so that we could work closely together rather than just talking about how to get to not include law enforcement when it may be necessary.
Thanks for that, Chief Harding. And I'm reflecting on something Jessica said earlier about trust and relationships and knowledge of each other being pretty important in that response process. Kashi.
Thank you. Part of the reason I asked the question about if this is our only discussion on this is I understand why we started at the level that we did, but I think it would help at least me in future conversations if we could be slightly more granular or focused in how we think about that first question of what conditions would it be appropriate to engage first responders in what situation is hugely impactful there. And we having to spend the time to sort of parse out if it's this situation, I think that support in identifying what types of calls we might be getting or what type of issue the caller or person in crisis might be facing would help us map out ways in which we would articulate ideal state for response, because talking about it at one high level is really challenging. And I think it leads to the differing perspectives I think that you're hearing at the end of this, which is that some of us don't think law enforcement should be here if at all possible, and some do. And I think getting more granular in future conversations would be really meaningful, so that we don't have to only talk about this as one sort of monolith.
I think that's a great point, Kashi. Actually, when I was thinking about how I might synthesize this, one of the things I'm hearing is that, to use Jan's words, there is a continuum here of how people see it's appropriate to involve law enforcement or not. And I think that's an area where we can have some further discussion, but you're right that it needs to be more granular than starting at that top of the funnel like we did today. I see a couple of comments in here, and then I want to kind of synthesize and summarize so we can do preserve our last few minutes for public comment. I see from Kim M, better understanding of how the initial assessment and decision is made by the dispatcher on which entity to send. It seems like this is a key point. And yeah, I think there were a lot of questions about that, and that is a good place to have some discussions. And then from Dylan, a question: Are there or will there be opportunities for joint trainings? As it stands, it sounds like each level is training separately. So Dylan, I just want to make sure I'm tracking the question. You mean in terms of training for law enforcement or fire or EMS on and also 911 respond, 911 triage. Did I hear you?
Yeah. Yes, and the mental health teams, or whatever, it might be a co-responder, it might be the crisis response team, just being able and I haven't done any of those particular trainings yet, but what does it look like of, I know, a live run, we get a call, what happens next? And so I think people knowing their part, and also not exactly cross training, but knowing enough to what to expect from each part of the team.
And I just see a chat message in here from Representative Orwell. House Bill 1134 does joint training of first responders, 988, 911, and behavioral health. So that's an opportunity potentially. And I see some claps from Dylan. We are running out of time, so I do want to say a few words about next steps. And in response to Kashi's question, first of all, I just want to thank all of you for getting us going with this conversation. I'm looking around, I'm seeing almost all of you were engaged in this discussion, and I really appreciate you sharing your personal and professional experiences and having this dialogue together. As we mentioned at the beginning of this has been a topic that's been kind of at the top of the list for almost a year now. So I'm really pleased that we're able to start having this conversation. I want to reiterate the steering committee will be drawing from these discussions to formulate recommendations. So the more clarity that they can get on areas of converging or diverging perspectives, the better. Last year's ad hoc work group to pull together a vision for our CRIS work seemed like it was a pretty effective model. So we had a thought that might be a good follow-up step here. And we propose that we continue this discussion through a time-limited work group of CRIS committee members. Considerations would be brought back to the full CRIS for more discussion. And the goal of these discussions would be to provide the CRIS committee with some guidance for their deliberations. So I think what we'll be doing is, if that's something that sounds good to you all, we would follow up with next steps. I believe the vision group was CRIS committee members who stepped up and volunteered to participate in that, but also recognizing that this is going to require representation from different groups. There may also be some outreach that we will do to individuals to invite you to engage. So any questions about or concerns about that as a next step? Okay, gosh, an hour goes by so quickly. I appreciate everyone engaging on this. Let's go to action items and next steps. Nicola, I think there were a couple of follow-ups that HCA was going to do for us. were there any other action items or next steps?
I think just formation of this work group and then also flagging that there was a request for volunteers to participate in a work group in the newsletter. So those are two separate work group requests out there for CRIS members.
Thanks, Nicola. And actually, sorry to take us back, but I do see a chat in here from Vipasha that I think sort of nicely. Vipasha is really good at the close, I gotta say. So let me put this out there for you all. There's a lot more common ground I see than we think. No one said that no law enforcement ever for anyone. Seems like people agree that's not realistic, that the reality is nuanced. I hear most people agree that behavioral health experts are needed in every response system, all types of first responders on behavioral health issues, more or a lot more, and in time, stop making police going to respond to everyone for everything, and 988 will be the place people turn to for behavioral health issues. It will take time, but that's what we want. We want to bend the arc of the behavioral health system toward justice, to quote Dr. Martin Luther King. Yeah, Vipasha, like I said, you are the queen of the close. Nicely done. Again, thank you, everyone. I so appreciate your engagement today, and look forward to our discussion on youth and young adults at our next meeting. And now I'd like to move us to our public comment period. We have a more robust list than as I mentioned, than we have at our last few meetings. So I am going to use the timer. I just want to remind folks about how we do public comment. We can do 2-minute comments because we do have enough time for that. So I'm going to put the timer on the screen. However, folks who signed up, if you need an accommodation, you need a little more time or the timer just makes you anxious, please let me know, and I will take it down for your comment. Also, I'm going to ask our commenters, if you do have a written version of your comments, if you wouldn't mind sharing those with us afterward. That's a way to make sure that our members are able to read it and take it all in. Let me share who's signed up. We had a few people. Sign up during the meeting. So we have Deb Blakesley going first, and then second is Kristen Wells. Third is Rhonda Larson, and then I think it's Shriram, and I apologize, Shriram. I think I always butcher your name, and I'm so sorry. Shriram Rajagopalan is going to go fourth. Deb, if you're ready, if you could put on your video camera, I'm going to share my screen with the timer. And Deb, when you're ready, you can go ahead and start.
Okay. Someone from the Lived Experience Subcommittee sent me a link to SAMHSA's 80-page best practices report, the National Guidelines for Behavioral Health Crisis Care. From my lived experiences, I see gaping holes in this report. One, the only prevention mentioned was around ending one's life, not preventing harms perpetrators intentionally inflict onto innocent victims this week or decades ago. The definition of who the crisis response system helps leaves out my crises. I did not have mental health or substance abuse issues. Instead, someone was intentionally, increasingly harming my life and falsely accused me of something that thankfully I had documentation to prove my innocence. Then he gave me an illegal one-day eviction notice I couldn't afford to fight, leaving me homeless, without transportation, without income, and without most of my possessions, but with boatloads of understandable anxieties. Number three, in the report, there were no empirical evidence that was offered or mentioned of expected outcomes for individuals in crisis, the steps taken to assess, de-escalate, or resolve their needs, and how outcomes for individuals are measured either qualitatively or quantitatively. Instead, the report offered LOCUS, the level of care utilization system, which was developed strictly for psychiatric and addiction services of varying levels. Measurements do not focus on outcomes for individuals. Instead, the measurements were about assessing infrastructures and how much money was saved and how many people were referred into or out of varying levels of psychiatric care. I did submit a written version with page references. Please, we need a system, and I know it's under under progress, but we need a system that genuinely addresses crises, preferably long before the crises happen.
Thank you so much, Deb. And I should have said earlier that our CRIS committee members will not be responding to the comments. And Deb, so appreciate you submitting your written comments too. That's super helpful. So thank you. Okay, next up is Kristen Wells, followed by Rhonda Larson, followed by Sriram. I'm going to say Sriram R. So Kristen, when you're ready, please turn on your video camera and I'll start the timer.
Hello. I wanted to share some of my professional experience. I know I talked about my personal experience earlier. So I started out in the mental health system working in a community mental health clinic in Rainier Beach. And most of the time when we were involved with first responders, it was because there was a client that came to the clinic, expressed that they were having a mental health crisis. And in our work with them, we weren't unable to reach a safety plan or adequate support for them at an outpatient level. And at that point, our only option was to call 911. If a client was willing to go to the hospital voluntarily, emergency medical response was usually who responded and was able to get them in an ambulance to go to the emergency room. But where the biggest issues tend to happen would be if someone was unable to make a safety plan, we weren't able to come up with a good option for them outpatient, and they were unwilling to go to the emergency room or into inpatient treatment. Those were the calls that we generally had police respond to. And sometimes the outcome of that was good. The police would be able to get the person to go with them to go to the emergency room involuntarily. But sometimes we would have other outcomes, such as a person being arrested for an open warrant unrelated to their mental health crisis, or the police wouldn't be able to see what we were seeing as the mental health professionals and would choose not to take the person to the emergency room. So that's kind of the circumstances as a mental health provider where I'm interacting with first responders related to mental health crisis. That's all I've got. Thank you.
Thank you, Kristen. All right, next up is Rhonda Larson, followed by Sriram Rajagapalan. Rhonda, when you're ready, turn on your camera and you can go ahead and start.
Thank you for the opportunity. I really have a deep appreciation for this work and the challenging and professional discourse that you all engaged in tonight. So thank you for your work. In particular, the conversation that surfaced tonight regarding a need for a dedicated specific focus on youth mental health. We're seeing youth in our schools with so many behavioral, mental, and substance health challenges and have such limited access to services, even though we dedicate a substantial amount of funding in an effort to try to fill those needs, and much of which goes unspent due to lack of resource, lack of access. In a perfect world, our partners would represent the cultures from which our students identify. When you do make space for this conversation, please invite school districts and youth serving organizations to hear their voices. Prevention and early intervention is going to come back to us in gold. We can't reach and teach kids who are not feeling safe in our schools, and we must have partners in this work. You guys are uniquely positioned to help us in that work. So I thank you for listening, and I stand to serve whenever you need.
Thank you, Rhonda. Next up is Sriram Rajagapalan. Sriram, when you're ready, go ahead and turn on your camera and start.
I'm ready. Hi, folks. I'm a community member with lived experience. I'm also familiar with some folks here because I serve on the CRIS Technology Subcommittee currently. So I've been listening to the discussion today around co-responders, and it's clearly a challenging topic with lots of opinions and lots of problems to be addressed clearly. And it's hard to tell when co-response teams are formed to cover gaps in the crisis system and when they're there to provide the services that I think they are primarily trained for. And so speaking as a community member, I'd like to see the system operate in a way the response is tuned to the situation of the caller. It shouldn't matter whether I call 911 or 988. Just because I call 911 when I'm having a behavioral health crisis, when there's no other medical or safety issue, I don't want first responders, especially law enforcement, to show up. If a mobile crisis response team is available and can meet the response time requirements for my situation, that is the team I'd like to see show up. Similarly, just because I called 988, if there's a need for first responders or law enforcement to make the response safe, then they should go along with the mobile crisis team. Unfortunately, we have a situation today where we have far more first responders and law enforcement resources than we have behavioral health crisis response teams. And hopefully this CRIS effort is going to make this crisis response system a lot stronger with a lot more resources. The bottom line is that the team responding should be optimized to provide the most appropriate and trauma-informed response that best meets the needs of the caller and provides them the services that helps them recover and get to a better place as fast as possible. Thank you.
Thank you, Shram, and thank you to everyone who made comment today. Again, if you have written versions, I know Deb, you've already sent yours. If you have written versions, you can email them to the HCA email box. Let me pull that up and put it in the chat. And of course, also, if you did not make a comment today but have thoughts you want to share, please do send them. Oh, thank you. Chloe's on the job there. Chloe just posted it in the chat. We do compile those comments and share them with CRIS committee members every month. So please do share your thoughts on today's conversation or any of the work that's being done here. It is just almost that time. I imagine after a 3-hour meeting, you're all pretty tired and ready to take a break from this. So I just want to end by saying, as ever, I appreciate each and every one of you, CRIS members, community members who take time every month to engage, not just in this meeting, but I know a number of you are also engaging in subcommittees and steering committee members who are doing the deliberating and processing of this information, and agency staff, in particular. A big shout out to HCA staff who worked very hard on that presentation today. I'm grateful to each of you, and I'm especially grateful to our folks with lived experience who come here and share their own experiences. It really does inform the work, and it's really, really important. So thank you all. I wish you all good health and a good evening, and I look forward to seeing you next month. All the best.
Did you practice? You were like right at 10 seconds. I think lots of